Hello, welcome to the IVF Doctor. Today we are trying to go through the entire process of IVF. The goal is to let you become aware of the processes of IVF and to see how we can ensure that you understand the entire process from your point where you are now, wherever you may be in trying to conceive, to the machinations of essentially not just even IVF, but trying to expatriate within assisted reproductive technology. So we're going to see how we can dive into IUI, follicular tracking, IVF itself, ICSI, surrogacy. It's just an entire course on what it takes to get into assisted reproductive technology, to get assistance in your reproduction if you're having issues with getting pregnant. So let's see. I'm going to be taking some notes myself when I speak to you, and it'll be good for you to get a note while you are hearing me right now. You might want to get a notebook so you can jot down some things. You can also jot down some questions because it's an extensive session. I don't presume that you will get everything at once, and that's okay. If you do, wonderful, kudos to you. But if you don't, it's also fine. We're going to see how we're going to cover everything that you need so we can answer the questions that I keep getting from thousands of people consistently. Let's see how we can get those answers to you today. So, yes. Okay, so I like a notebook on my own end, so let's begin. All right, I'm going to put on my glasses. Usually you see the reflection of the light here because of that sometimes, but if it's there, it's all right. It's just because I want to see properly to attend to you. All right, so what you should know is that these processes that we're going through, they've been simplified in a large number of ways. It's a simplified process. The idea is to make it as simple as you can get it. So there may be no big medical terms. I'm going to try to avoid them as much as possible. I'm going to try and avoid fancy jargons, fluff, It's just going to be direct to the point in simple English, very short. So if you can actually go through this once, it'll be very good so that you don't get confused when you're getting back to it. You can just sit down, set aside the time for however the length of the video is and go through. But you can also take it bit by bit, piecemeal. Okay. One thing that I understand is that it's not easy for you to prepare to go through what you're going through right now. It's not easy. It's actually a very complicated process. It's a very mentally exhausting one, and you are strong for even being able to do this, to come here for information. Many people, they just shy away from it, or being able to allow yourself get the help that you need, for being able to, for being able to prepare yourself in a way that you are able to now come to this particular location today, to this point where the goal is simple. Let's see how we can get you your babies. So the general introduction, the general outline of what we're going to be going through is a major focus of our talk today is IVF, but we're going to go through everything. So essentially, we're saying introduction to assisted reproductive technology. What does it entail? Then steps for screening for assisted reproductive technology / IVF, explanation of the steps for IUI, time data course, follicular tracking, those things. Then we'll also we will also dive into egg donation. What does it take for you to receive eggs as an for your IVF procedure? We'll also dive into bonus topics like if IVF fails, what next? IVF, the truth about IVF success rate, say something about the cost of IUI, IVF surrogacy in Nigeria, using emphasis on Port Harcourt, Abuja, and Warri, current price rates, and also some form of conclusion, contact information, and anything else that also comes to mind is going to be something that we're going to be trying to be dealing with. So let's dive in. Let's dive in. All right. I believe you have gotten your notes now. So what you should know is this. Assisted reproductive technology is an advancement in medicine. That has made it possible for women that are finding it difficult to get pregnant to now get pregnant. Before now, in those days, what actually happens is if a woman cannot get pregnant, that's the end. There's nothing beyond that point. she can't get pregnant. Sorry, is either she gets somebody else's baby, maybe she gets a younger wife to come and sleep with her husband to get pregnancy, or some other machinations that may occur. A man may get his brother to sleep with his wife so that he can't get a child if he's having issues impregnating a woman. There are things like that that were happening back then. However, with the advancement of technology, with the advancement of medicine, there came a day and a time where we are now able to step into fertility support, which means that a woman that is not getting pregnant no longer has to stay like that. A man that is seeing is having issues no longer has to stay like that. Instead, we now have methods of assisting this couple, and the methods they vary. It can come into something as everybody thinks of assisted reproduction, and they consider IVF, but that is not what it is. That is not even the beginning of it. IVF is not the first or the second option that comes in assisted reproductive technology. One of the first things that we usually would do, in fact, the first step for everything that actually you want to do when it comes to ART is finding out what the issue is. And this can only be done when you've gone to see a doctor, and then they go through the next step of testing you across multiple variables, across multiple dimensions, anatomically, physiologically, like biochemically, hormonally, if you are breaking it down, if you are coming down to that point. While looking at a lot of things, want to know, is there anatomical function of your body okay? Are there defects in the physiological production of certain things? Are there defects in hormones? When we have looked at this, and then we can now have an idea as to what to do. And one of the simplest things that can be done most times is optimizing the time and the duration of the number of times and the timing of sexual intercourse. So this is how it goes, right? Okay, so I'm noting you should note as well. So because I want to be able to go over some certain things very well. So when couples come in, I've had couples, not a couple, I've had couples come in, and usually they come in and they say, "Doctor, I want to do IVF. We've been trying for a year, we've been trying for 2 years, my wife is not getting pregnant. I don't want to waste time, I just want to go into this. Just tell me, money is not the issue, I want to do this IVF." And then we ask them, okay, we do the preliminary questions, because before we even go into testing, we have to get a full overview of your life, a full overview of what you've been doing, how you've been meeting your husband. Yes, we ask you how many times are you having sex. We ask you, yes, we ask you how many times are you meeting. We ask you, does he release into you? We ask you as many questions as possible. And we find sometimes that the very first thing is optimizing timing. There are couples that have come in ready to do this IVF, but the reason why they're having issues is because they've not optimized intercourse for ovulation times. They've not optimized their meeting for the time when the lady is ovulating, either because they can't count it properly, or maybe because of the nature of the man's job. Sometimes it might be working a long distance job, maybe a long distance driver. It can be somebody that's traveling a lot and is really around at the right time. It could be someone that is maybe within the military. It could be someone that is working offshore or overseas, or any of those things you get. When this come in, we try to see how we can now optimize timing such that we help them calculate what the ovulation period is. And in the calculation of the ovulation period, one of the common mistakes that we actually find is, you hear that ovulation is 14 days. So most people are going to count 14 days from the beginning of the period. So a woman sees her period on the 1st, she has 14 days to that and presumes that on the 15th, that is her ovulation period. But that is not how it works. What actually happens is that the ovulation period is something that the ovulation period of a lady is estimated as 14 days from the ending of the period. 14 days from the ending of the period. I want to say 14 days from the ending of the period. We are saying that for that lady that now has, let's say, 30 days as a period, we're now saying she should count, okay. All right. So we're saying that she should count 14 days from there. She takes 30 days, subtracts 14 from it, which is on the 16th, and presumes that that 16th day is a day of ovulation. However, that is not enough. The reason is, except you are using ovulation test kits, which are commercially available, you can get them. There are ovulation test kits that you can get and use at home without any doctor's support whatsoever. Aside from that, since you're not using a test kit, you're not taking medications, we call that an estimate. Even with the test kit, you still have to estimate the day before you can test yourself and see around that time what is actually going on, because it's a subtle thing if you're not tracking with scanning and some other factors, and some other parameters. So what happens here is we'll tell you it's not just going to be on that 16th that you are going to meet. We will tell you that I go for about a week. But in that week, we're saying 3 days before that your ovulation day and 3 days after your ovulation day are the times that you want to actually be meeting your husband. So in the 3 days before your ovulation day, what happens is, even if you are meeting and the ovulation comes before that particular date, for this case in point, we are looking at the 16th, it means that you are still within the time of ovulation, and that woman can still get pregnant because the sperm can actually survive within the lady for up to 72 hours. 24, 48, 72 hours, it can be there and it can still get the lady pregnant. Then if you take that one out of that, then 3 days after that, even if the semen is coming in after the egg has been released, then it can still help the woman get pregnant. So that's how we usually go. So that's why intercourse for that period is going to span across the period of a week, so that you can optimize for this. However, even before this time, the actual number of times that a lady that is trying to get pregnant should be meeting her husband is about 3 to 4 times a week. Of unprotected, meaning there's no protection whatsoever, you're not using any form of family planning, and is pouring into you, unprotected, regular meet up. That is what it is. This has to happen for a period of 1 year if the couple are young, below the age of 35, and then when they don't get pregnant, we can now say they have issues. Or a period of 6 months if the woman is, or the males, if they are more advanced. So usually couples above the age of 35, we don't wait for 1 year. We'll let them navigate for about 6 months before stepping in to see how we can support them. So that is a note on the ovulation period. This also leads me into just a brief conversation on what some people try to do to get, when they are trying to get a male or a female child and they are not using any IVF techniques or pre-genetic screening. What they try to do is using this information I told you about the ovulation date, because studies have shown us that the male semen is faster than the female one. However, it dies faster. It's weaker in the woman's body. So what happens is the woman will want to meet sometime a few days before ovulation. If she meets a few days before ovulation, let's say 3 days like we were talking about before, and the man releases into her. He releases his male and female semen. They are running, everybody's going, the males are faster, although weaker, they are dying maybe because they are meeting up with cervical mucus. But however, even if it's the first ones that get there, there is no egg. So what happens is, because they have less resilience, they die out, leaving the female semen to probably be the one that is more likely to fertilize the egg. When they want a male child, however, what they are now going to do is meet presumably on the day of ovulation, so that as the egg is being released, they can fire in and see what happens. So that is a side note on determining gender that some people try to use. Of course, it's not 100% accurate. We cannot even tell you that is definitely what we advise you to use, but it's a method that we'll also consider and do use sometimes when we're not going for PGT and we're just trying to quite naturally see if we can get a lady pregnant with the particular gender that she wants. And it does happen. It does work. It does work like that. So that's for that. So let's go over to the next point now. Let's go. So that is a brief overview of assisted reproductive technologies. We've made a note on ovulation periods, gender selection as well, using non-assisted reproductive technology methods. And we're now going into let me give an introduction on IVF. Okay, so the first thing to know about IVF is the meaning. What really is the meaning of IVF? IVF means in vitro fertilization, and what's that term actually just trying to tell you is it is being done in a lab. It is done outside the body, it's done in a test tube, to be literal in the way the word means, and it's being done in a lab. Vitro means glass. So that's what they're trying to say. And what we're trying to say here is that we're taking the eggs out of the woman's body and taking the sperm out of the man's body, putting them together in the lab, letting them start developing into forming the embryo, forming the baby, and then moving into the next point, which is letting them develop and transferring it back into the woman's body. So that's what we call in vitro fertilization. And that is what IVF essentially is. Then another term to define here is donor IVF. When we say donor IVF, we're saying that maybe there's a problem with using the male's sperm or using the woman's egg. So what we do in this case is that we don't tell you that no, it's impossible to get you pregnant. No, you have to go back. That's the end of it. I'm so sorry. No, we have options. So we've also been able to have advancements in medicine that allow us to have a donated sperm or a donated egg from a younger lady, from someone else, that we can now use for the procedure. So what we're saying, for some ladies, they tell them, oh, you are likely going to have to consider donating eggs, especially when the woman has gotten to the age of menopause. At that point, our egg reserves are already depleted. She does not have enough anymore. The quality of those egg reserves are in question. They are probably largely genetically defective, and we opt for a donated egg. For a man, maybe he's having a zoospermia complete and total. There's nothing in the semen. We'll try to see, is there any obstruction that is causing it? There's no obstruction. Is there anything that we can identify as the cause of this? There's no identifiable cause. Then we'll see if, okay, you can even, maybe they've even gone as far as saying, okay, let's do extraction for this male, testicular extraction. Okay, we'll go in, try to extract. There's nothing there. You have to now move on to the next point, which is a donor sperm. Somebody else has to donate his sperm so that we can use for the procedure and get the woman pregnant. So, yeah. So another thing you should also note another term is cycle. You may hear this is one cycle, this is one cycle, this is one cycle, this is one cycle. And so what is a cycle in IVF? Some people will ask, oh, you are being asked to pay a certain amount of money. Are you paying for 2 cycles or are you paying for 1? What that simply means is going from the point of when your medication started to the pregnancy test. That is a cycle in IVF. That's what they are trying to say. So what they're trying to say is, okay, the analogy, you come into the clinic, you've done your testing, then we decide that we're going for IUI, we're going for IVF, we're going for follicular tracking, whatever it may be, and we now see, after doing that, then we'll get to the point where we'll wait for the time to see if you are pregnant. From that origin to the pregnancy is one cycle in the procedure. Yeah. So what is follicular tracking? Okay, follicular tracking. Let's leave that now. So when we step down into some other terms, we will now start discussing them. So I'm going to start with the general steps for assisted reproductive technologies and assistance, how we can help you. What usually happens is, you know that the beginning steps are the same. I'm going to break down. You can leave them as 3 to 4 steps only. However, what is going to happen is I'm going to make it more broken down so that you can understand every aspect of it. So that's going to make it a bit lengthier, but hopefully also better for you, so you can get what is going on. The beginning steps of every fertility journey usually are like, the first one is you have to get to the clinic. Although there's a preliminary phase that we don't usually include in our own conversation, and that is research and your own checkup, which is what you are doing right now. You are researching, you are finding out more, you're trying to understand more of what is actually going on, trying to see what options do I have. This is a preliminary phase. It has to happen before you come through. But the first contact that we have with you usually will be a consultation. The ideal contact, beyond maybe booking an appointment online, would ideally be a consultation. So I was taking that as step 1. So you can take note of that and notice as step 1 of what you need to do for your own fertility journey. And the consultation just means discussion with the fertility expert, discussion with the gynecologist or whoever it may be that you are seeing at the moment. It could even be your GP or your primary physician that you have your first conversations with. The idea is they want to know your medical history, they want to understand what you've done before, what method have you tried, what is currently going on, all of that. So by seeing that, we can now understand where we are going to come from. Some clinics may or may not on this very first visit do a scan for you to try and see maybe a bit of the anatomical structure. So it's a consultation, a discussion, examination, is all of these things rolled into one. That is your first visit. So prevention, if you were to see a GP before coming, it's highly likely that the GP is going to refer you now to a fertility expert, an ART expert, could be a gynecologist, whatever it may decide to send you to. But that's when you come now, you do your consultation and all that again with your fertility supporter, and let's presume that you still will do that, and then that is what will now guide us into the next step and inform us as to what do we need to do. There's a common saying that I have when it comes to what we need to do for patients, and it is this: we are simply the mouthpiece of the body. You may presume that as you are coming in, that I have a preconceived notion as to what the options are for you. I know what you definitely need, or any other doctor that you're going to see, but that is not really what happens. We are simply the mouthpiece of the body, in the sense that what your body tells us it needs is what we are going to follow. What we see from the examination and the testing is what guides us on what we are going to do. So we're just listening. We're receiving feedback based on the knowledge that we have, and then using it to attend to you and give you the best results. So that is what this consultation step does for us. It guides us on the next step, and the next step is testing, evaluation. In this testing phase, we're looking at a full checkup. We're trying to see the entire internal milieu of you and your husband to understand what is going on here. Why are we having delays in getting pregnancy? What is causing the issues? We would prefer to identify a cause so that we can know that this is the cause. And it will interest you to know that when it comes to the cause of male and female infertility, we are looking at, the studies have also shown that it's equally proportioned. So you have about 30% of it coming from males, 30% of it coming from the females, and on that 30%, that is a mixture of both a male and a female factor. But we now have another subgroup, which is 10% of them are said to come from unexplained infertility. So what do we call unexplained infertility? It means that for all practical purposes, by all evaluation and review that we have done, we cannot find an identifiable cause for this delay. And because we cannot find an identifiable cause at that point in time, maybe medicine has not gotten to the point of being able to understand what the cause is. Maybe the resources are not there to go that far. But it now means that we are going to approach you as unexplained infertility. We're not sure what the cause is, but we'll try and optimize everything that your body has so that we can see how best we can make things flow. So if you've gone to the hospital and your blood has been tested, hormones has been tested, fallopian tube scan, you've done hysteroscopy, semen analysis, AMH, whatever it may be, and you find out that there's no problem. It's not. It does not mean that that's the end. It does not mean that that's the end. That happens. It's interesting to know that as humans, we are not very fertile. We're not very fertile as humans, as a species. If you want to make a comparison of this, look at how the dogs, the rabbits, how they get pregnant. With ease, right? Very rapidly, rabbit is pumping out hundreds of hundreds is an exaggeration, but you get the point. So they are pumping this out, and it's not so for humans. A fully healthy male in the best of health and a fully healthy female in the best of health could continually have intercourse up to 3 to 4 times a week without any form of protection, with proper ejaculation in that situation, and still have difficulty getting pregnant. They may not get pregnant within the first month. Ideally, if they are a young couple, they should get pregnant within a year. But that should give you some form of insight into the nature of the issues that are actually here. So that's one of the reasons why we do so many tests. And after the tests are done, the test will now lead us into the third point, the third step that you need to follow. And the third step that we're looking at is what we call the result review. Tests are not just going to be done and forgetting about. They are not just being done because we want to spend money, or because it is written somewhere in the book or the annals of medicine that when the patient comes with this particular issue, you do this. No. When tests are done and the results are out, there's a need to see your doctor. When tests are done and the results are out, there's a need to see your doctor for a result review so that we can now identify what your options are. So for some people, we find out that there are multiple options. IVF may not actually be the only option for them, which is generally true for a large segment of persons, especially when they come in at an early phase. Especially when they come in at an early phase. So if the lady, if they come in when they are, if they come in when they are young, then they usually have the option of coming to certain other options like follicular tracking, IUI, that is intrauterine insemination. We'll also have timed intercourse, that's also falls under follicular tracking. Then we can even try whatever methods we actually have. Medications as well is actually an option that comes in. There are people that, and this happens. I remember a patient that we had some time ago in the UK, and she wanted to come in for IVF. She reached out after evaluation. We had a conversation, had a fertility review, and we are convinced that this lady could get pregnant without having to come down to Nigeria for her fertility procedure. So what did we do? We sent her some tests to do. She did them, sent her results back to us. We reviewed the results, prescribed medications for her. She got them where she was, commenced her medications, and today she has a very, very beautiful baby girl.
If you like this video and you want more information about fertility, IVF, babies, surrogacy, IUI, and many other fertility procedures as well as medical issues, kindly subscribe, share, and like this video for more.
Very, very beautiful baby girl. Sweet baby girl. Without having to do the IVF. Without having to travel down from where she was to Nigeria for a procedure. What am I trying to say here? Sometimes it's not IVF that's the answer. There are other options. So drugs can actually come into play. But if you've been on medications, if you tried those ones who are not getting resolution, because one thing you should actually understand about this thing is that the doctor is not a miracle worker. He's not a magician. What he actually is a scientist. That's what we are. We're scientists. You come to us today, you tell us you're having this issue, you're having issue A. We look at it that based on what we know about issue A, based on the knowledge that we have, based on what we have seen experientially and in our own practice, we understand that when there's issue A, if you go with option B, you are going to get a resolution. Now, however, we also know that everybody is different. In fact, that is where medicine is going to. Where medicine is going to is a point where we can individualize your care. It is not general care. It is specifically tied to your DNA. I think medications, I believe, will get to a point whereby you want to get your drugs. Let's say you want to get acetaminophen, Advil, paracetamol, antibiotics like amoxicillin, penicillin families, or whatever it may be, and it is matched to your DNA, such that the medication can work for you, but will not necessarily work for the person by your side because it's a DNA-based matchup. And I think we're getting there. But that is also what we're trying to do here, in a sense that, about doctor's care. Okay, in the sense that we're simply listening to what we see. You come in, we see, we've done our testing, we found reviewed the results, and we see that okay, maybe this person does not get pregnant after a month. Usually we are looking at about 3 months. The woman does not get pregnant, and we say, okay, this method is not working. We've tried time intercourse for the first time, we tried time intercourse for the second time, we tried time intercourse for the third time, and that is not working. So we're not going to do that anymore. Let's now move to something else. You understand? So when we try something else, it works, it does. If it works, we know that we are done. That's the end of it. If it doesn't work, then we understand that okay, that is not what is working for that particular point, and we have to now consider other options. So we move on from that point to other options. So you see how it works. The doctor is a scientist. He's not a magician. He's not a miracle worker. So that you understand what we are doing. But experience, research, and advancements in medicine has given us an edge. So we now have a largely better understanding, hypotheses, guess, predictions as to what we are dealing with per time. Thank you very much for that. So let's just see. Okay, so that's what it is. So we do our results review, and after doing our results review, we now understand what it can be. So it could just be simple lifestyle modification. It could be medications. It could be some basic, less advanced ART procedures. Before we now consider IUI, IVF, within IVF, donor IVF, and its machinations that may come within it. If that does not work, we're now going on to surrogacy before we now move on to adoption as an option. So the point is, there are options. But the earlier you start, the sooner you get your results. Some persons are facing a lot of difficulty in their fertility journey today because they are starting so late. I find that a lot of times within my climate and within my country, Nigeria, people come to the hospital for fertility support when they start missing their periods. When their period starts skipping, that is at the point whereby menopause is already knocking on the door. And the chances of success are better at younger ages than older ages. So let's put a note on the chances of success here. I hope you are. I hope you are following this. I hope you are following this, and you have put down. You are taking some notes as well. Okay. Yeah. So chances of success in IVF are usually better. Do not be deceived. They are better in a younger age. Does that mean that older ages cannot do it? No, absolutely not. Older ages can do it. We have patients that are 50, 56, and 56 years old, did the IVF. There are patients within this age, they have only the IVF once and got pregnant. Coming to my mind now is a lady with a very fair, beautiful girl, celebrated her 1 year birthday a few months ago. I recall because her husband happens to be, his name is Peculiar. His name is Peculiar, so I recall him a lot. And we met recently at some time. So it comes to mind at this point. And he was so happy to see me, But the thing about it is, she was 50. Single trial. Went in, did 1 cycle of IVF, got pregnant, moved on. She has a baby. Was really on that one. So the point is, it's not impossible to get pregnant at older ages. But why come in with lesser chances? Go for the optimal, go for the best. So at younger ages, a woman that is below the age of 35, within 35, late 20s or whatever, you can see that if you check what the records are, you can see some people claim to have about 60% chances of success for them, 60, 70, some will even postulate as high as 80, some will go down to 50. But the point is that they have the best chance of success. And you can check to see what the standard results are. But even within the standard results, you find about 60% to survive IVF as the average that comes into it. Now, if you want to now look at the chances of success for the age that is now 45 and 50, you now find out that, especially when you have to delineate, you actually have to delineate into looking at it. Because yes, the summary, some people will say 60, whatever, for the younger ages. But if you want to balance it, you say 40, 50%, right? Or 55% or 60%, whichever way you want to cut the knife. But when you're now looking at the chances of success for women that are at the age of, let's say, 45, and at this point in time, they are now, let's say, using their eggs, you find out that there's a steep decline in the values. You can be seeing 5% above the age of 40, 45. Yes, as a chance of success. Some people are very generous estimates. They will say, okay, 8% above the age of 40. When you come down 40, 45, when you come down to 50, the chances drop. So you don't need to put yourself in this kind of scenario. Do it as soon as I'm saying that even if you're adult age, that's not a problem, because also one of the let's say that's not a problem, you should not be discouraged. One of the reasons why donor egg often tends to come into play in older ages is, apart from the declining quality, the lower chances of success, studies have also shown that with the use of donor eggs, you are likely also increasing the chances of the woman that is doing IVF. Some people say it's as high as doing, if you use the eggs of a 35-year-old or 25-year-old, you are essentially giving the woman that is doing the procedure that same chance of success as well. There are lots of schools of thought on the topic. We're not here to dive into what is right medically and what is not in those areas, in that area. So it is not for you to bother about. What you should just take away from this is the chances of success improve when a donor egg is used for women that are above the age of 40. It does improve. However, if you are not yet there, go and do your procedure. It's the best thing for you. The earlier, the better. The best time to have done any assisted reproductive technology was today. Today for now, but the truth is that it's actually yesterday. Why the next best time? Now. Now. Start today. That's the next best time. Whatever moves you made before that have worked or not will do not matter. Start today so that we can see where we are going to next. So let's leave that point now. We'll flog that. So let's go on to okay. Oh, where's my guy? Okay. So yes. So okay. So there's this common question that comes up here. What is the requirement for IVF? What is the requirement for IVF? The answer to that question is very straightforward and simple. It is not, I know this is not exactly what you are looking at, but the answer to that question is that the requirement for IVF or any fertility procedure whatsoever is that you are having difficulties getting pregnant and you are screened by a doctor who now determines what the best thing is. Once it determines what it is, that's it. That's the requirement. Although I find that this question often comes in in a different context where what they are trying to find out is if I've been trying to get pregnant for 2 years and I've not gotten pregnant, can I do IVF? If I did SSG or did the stereoscopy or hydroscopy or whatever it may be, or SSG, yes, or SSG or whatever method that's been used to try and ascertain the nature of your tubes, right? And you find out that both tubes are blocked, and I do IVF. Those are the questions that are actually coming up, right? But those are a different thing. The point is, if you're having any issues getting pregnant, go to the hospital. The doctor will review you and tell you the best possible option for you. Okay, let's move on to the next point. So we're going to point 4. Okay, so this at this point now, what we're now looking at is what is the option that you actually what is the option that we are following for you? That's what it is. What method are we using for you? So this is where you put out diversify. Remember, I told you that the first 3 steps for every IVF procedure are the same. ART procedure are the same. You have your consultation, you have your testing, you have your results review. After this is done, the next step that comes into play is now going to diversify. So what we're going to do first is that we're going to go into the steps that are required for IVF. They will now break down into surrogacy, IUI, all of those things. Simply because IVF is the mainstay of the conversation that most of you here are having with me. So that's why we're starting with it. So let's do steps for IVF. So we're going back to step 1. For the first step in IVF, we're going back to consultation. For the second step, you are going back to testing. For the third step, you are going back to result review. And then for the fourth step, which is the commencement of the cycle, IVF, we've done your review, concluded that an IVF is what you need. Then we'll start going into the commencement of the procedure. The commencement usually is signified by the commencement of drugs. You can also say stimulation, drug stimulation, whatever it is. And the idea is that usually we have 3 main goals. The goal is going to be dependent on if we are doing your own egg and own sperm IVF. So we call it, sometimes some people call it own egg IVF, own sperm IVF, or self IVF, own egg, own sperm, or self IVF. What these terms simply are all trying to encompass is using your egg and your sperm, or one of them at the very least. While otherwise, you now hear the term donor egg, donor sperm, donor embryo. Donor embryo is basically the egg and the sperm are donated, and they are both donated. So that we'll call it donor embryo. So that's what it is. Then, what is now the goal of drugs and stimulation? Usually, we want to start with controlling your cycle. So when we say controlling your cycle, is that want to take a hold of it to an extent so that we can now use it to plan properly. So we don't want it to be haphazard or in any direction. So we'll place you on medications. Usually what you find that are being used around for this thing may be some contraceptive kind of methods of contraceptive pills usually come into play. And the idea is to take charge of your cycle so that we can now determine when your cycle is beginning and follow it into when it's ending, moving from there and use it for the process. So that is step. That is one of the main goals. That's goal A. Then goal B is if we're using your eggs, we're also trying to boost egg production. So what happens is normally when the woman, the normal process of the normal way of the normal route, let me use that one. The normal route that the body takes when trying to get a woman pregnant every month is a number of eggs are prepared, and one of them becomes the dominant one, the dominant follicle. I will use the word egg for follicle. I'll use the word egg for follicle so that you can track, so you can follow it. So one of them becomes the dominant egg. In becoming the dominant egg now, the next thing that happens is the body waits to see if she's gonna get pregnant. If you are gonna get pregnant. With that one. That's what mostly happens. So that's why you see that most people are giving birth to one child because only one egg is usually the dominant follicle. However, sometimes it can be more than one. That way you now see twins or triplets. Sometimes though, you should know that twins or triplets are not necessarily coming from that. So they may be coming from a singular egg that will actually develop and split at some point into two or three, and then that's where you see identical twins, identical triplets, and all of those things that are actually there. Mm-hmm. So sometimes I'm going to be posting like this, but I'm also taking my own notes, and I'm expecting that you are taking notes as well. So sometimes I'll pause just to jot what I'm jotting down before coming back to the conversation. Okay, so that's what it happens. So we're trying to boost the egg production. In the medications we are giving you at this point, what we are trying to do if we're using your eggs is that we want to produce more follicles, as many as we can get. This is also done very delicately to avoid some complications from overstimulation. So it's done quite delicately. It's not something that you just do in an haphazard manner. But the idea is we want you to produce more follicles than normal so that we have more follicles to take out of the body, more eggs to take out of the body and take to the lab so that we can use the sperm to now fertilize as many as we can get. That's what it is. Then the next point is, the next role that the drugs are playing, that is role C now, is to prepare your womb for pregnancy. Is to prepare your womb for pregnancy. So these medications are trying to prepare your womb so that even if you're in menopause now, women that are in menopause are going to replace some medications as well that brings their uterus, let's say their womb, to a point of readiness to receive the embryo, the baby that has been formed. So that is it. Then, so that concludes what usually goes on there. That concludes what usually going on there. So if it's a donor egg, what is happening now is that the two goals are that we're now looking at are regulating your cycle and prepare your womb for pregnancy. We're not trying to boost your follicles again. So that brings us to a point, boosting of eggs. Usually you find that a lot of women want their eggs to be boosted, especially after menopause has come in. They will say, oh, is it possible for the eggs to be boosted again so that she has as much and all those things? We generally don't go for that because a woman is actually born with the total number of eggs that she needs to have in her lifetime. It is there within the developmental phase of the woman at that time where everything was still primordial. It's already predetermined, it's already programmed by the body. So what happens is that when this programming is done, when the woman is born, these eggs lie dormant until menarche. Menarche referring to the point where she starts seeing her period. From that point henceforth, the body prepares one dominant follicle and then some other ones also try to develop alongside it. The body prepares them every month. And when you don't get pregnant, what happens? The body sheds them away. That is the menstruation that you see. The body is shedding the lining of the uterus, all three layers, three laminas that are there, the three layers that are there. The body sheds every one of them. Everything that is pertaining to that particular period, the body is trying to say, get out of here so that we can try again. This lady did not get pregnant. Let us do this again. The only time that the body is not going to do that for most people is when you are pregnant. That's why you see women are pregnant, they may not see their periods. They usually would not see their periods because they are pregnant. Okay, minute again. But I'm going to be taking a lot of minutes. I feel like I should tell you that because I'm also trying to navigate some things and respond to so some things at that time. Okay, all right. So I'm going to have some interruptions, but I'm trying to minimize them as much as possible as we go through. So yeah. So here we. So essentially, that's what it is for the donor. So that those are for the donor. For people that are going to be going with donor eggs, we're looking at two goals. For people that are going to be going with own self, whatever name it may be called, at your region, your clinic that you are using, we're looking at three major goals. When you have commenced your medications for this, wait until a point. I'll tell you that when your period stops, you take the medications for some time. I'll tell you that when you see your period, you call us, you inform us, you tell us whatever we will be done, whatever way you are told. Okay, so the next point is monitoring. That will now be step 5. For monitoring, what we're looking at is that throughout the process whereby your IVF procedure is currently ongoing, we're actually navigating the things that are actually being processed there, we're placing on medications. We're not just going to let you go. What will actually occur is that we would have to follow you up. Now, ideally and best case scenario, this happens with you around us. So, for example, you're in a different state, you want to do your IVF procedure, we usually say, okay, come around, come to our location, depending on what it is. Sometimes, for certain locations, there may be accommodation that you can stay in. For other locations, you may need to get accommodation around the area, or it might even be that you can stay with a friend, a relative, or something like that. When you are around for that period of time, for most people, with the protocols that we use, it runs about 6 to 8 weeks. But why I say most people is that remember what we were saying from the beginning about it being individualized. So some persons have to undergo a different procedure. That's why you see some persons may come for IVF. Maybe they have something like um uterine fibroids and they have to do a surgery to take it out before the IVF procedure can commence. Other persons may come in and what it may be is that they don't have uterine fibroids but they have maybe certain hormonal issues. You have to get placed on some medication to achieve some form of balance before you commence the IVF procedures. Others may have things entirely that prevent that require them to be on medication for a couple of months before you can commence your procedure. So it's different, right? But for most people, presuming that everything runs the way it usually runs, this is where we come to. And that monitoring period, so the entire IVF process usually, maybe timeline is something that we should look at separately. Timeline for IVF. Timeline for IVF. So for monitoring, what it is that depending on either ways, whichever person, but ideally depending on who is producing the eggs, that's who requires more monitoring, right? So if it's own egg, own sperm, then we're tracking, following the follicles on number of days. We tell you when to come in. We say day 2, we can say day 10 scan, day 12, day 14. We're tracking like that continuously, and we're following, and we'll now see how growth is going, how development is going. Also, titrating your medications according to what we are seeing, according to what we know that you need, according to age, according to a number of factors, right? This just helps us stay ahead of whatever your body is doing at that time and how your body is responding to the medications. That aside, this for this one now, if it's a donor that is currently going to be used for the procedure, a donor that is helping us out with the eggs, then the donor undergoes more consistent monitoring than the recipient because we're monitoring the eggs at that case at that point in time. So this also leads us to one of the things IVF failure in stimulation level. So I think we'll also come back to IVF failure and discuss the points whereby they usually fail and see how we can actually move from there to another point in time. Ignore my mannerism, so this is like a regular conversation. So that's why I'm not trying to be political correct and not do this and not that. So I can really see that we're real in this place, and I'm trying to give you as much information as I can. I want to be aware of what it is. Some of them may not be unpalatable. A number of it, like I know I've said failure now. And because I have mentioned failure, some persons are going to be uncomfortable with that. They wouldn't want they don't want to hear that IVF fails and all those things. And it's true, I understand that, but what's my goal and my heart cry is for you is to give you all the information that is necessary for you to go wherever you want to go to. Take note of that too. Wherever you want to go to, get your procedure done. When I say wherever you want to go to, I don't mean you should go to baby factories or school places with unscrupulous elements in the activities or vague, undefined things. Legal, regular medical procedures that can help exist, and I want you to actually utilize these ones. It doesn't have to be us. Your questions you can ask wherever you are, even if you know that you will never, ever, ever be able to come to us. Ask your questions. We'll do our best to respond. Yes, there are thousands of people reaching out, and it's taking some time to get responses back out, but it does not. We have people on it, we have medical doctors on it, we have people on responses to get sure that I am available. My mail is accessible through the website, through the YouTube channel, the Samuel Rotary at gmail.com. You can reach out, you can ask your questions in the comments. We'll definitely get to them and answer all of those things for you. So we'll get to IVF failure. Let me put that on that point as well, so that we don't derail and so we can move a little bit quicker than we are going currently. So that is that for the monitoring phase. The next phase now, which we are looking at, step 5, was monitoring. Step 6 now is oocyte retrieval and egg collection. So after the monitoring phase has happened, after you replace some medications, for 4, for 5, monitoring is occurring. We've now ascertained that okay, these follicles are mature enough. We can say okay, we can work with what we're seeing. The follicles have moved according to the way we planned. What next? So what we see is that we get to a point whereby the eggs that have been placed in the womb, and sorry, that have not been placed at this point. The eggs that have been produced by the ovaries need to be extracted. Remember what we said at the beginning about IVF, the meaning in vitro fertilization. The fertilization does not happen normally in the womb. So this leads us to the topic of fertilization, and it's something that unfortunately you still need to be aware of. Mhm. It's something that you still need to be aware of. Reason being that you need to understand what the process actually is meant to be and how is becoming defective, that is not allowing it to be that there are problems. So this leads us back to the causes of infertility, causes of this delay. But what it regularly would be is that for the way the human body is designed, think of the womb like an oven. Think of the womb like an oven, but this oven has two vents. So there are two openings left and right like this. There are two openings left and right like this. And there's one downward here. So this is the oven thing. Just let's use my head now. This my head now is the oven. This here are the openings that go out. And let's presume that the mouth is underneath here. And there's a connection here. So that is how it's meant to go. So this is how it now goes, right? For a woman to get pregnant, this ovum, which is my head, has to have the egg and sperm coming after they've been fertilized. They have to meet. So usually they are going to meet inside the body. What happens? My mouth, being the entry point, is where the sperm is coming in through when a man meets his wife. Both ears, being the external pipes, are where the egg is meant to come through. Now, where are the eggs? Think of the eggs as just these earlobes that are here now. So they are not the ear, but they are near the ear. So when they produce the egg, these tubes that are coming out of my ear now will try to pick them up, and they will come in. As they are coming, it's a long pipe. The sperm will go somewhere around the largest area of that pipe. We call that one the ampulla vata, but it's not really ampulla. Sorry, call it the ampulla rather. But it's not really relevant for you. Just leave that out. So they meet there, they get fertilized, and then they come back into the ovum to be developed. to bake, so to say, like the way you bake bread. But what happens sometimes is that you now get a situation whereby these two pipes are blocked. You say the fallopian tubes are blocked. If they are blocked, how are they going to pick up the eggs that are coming from the yellows? Sometimes you have things that block the mouth. How is the sperm going to swim and come in? You have things that okay, it can swim and come in, think I block it does not really block here, nothing blocking here, but within the oven is clogged with dirty bread of before or something like that. And therefore it's not possible for you to bake new bread. So those are some of the things that are actually happening. So fertilization process now is usually supposed to come in, mate, come, implant, pew, enter inside the womb like this. They attach to it, attach to it, attach to it, attach to it, and grow. The baby will now grow. The womb will now start growing bigger and bigger and bigger. Now start seeing it from everywhere. When I do the womb is usually the size of like the fist. Small, chicken, chicken, chicken. Below the pelvis cannot be felt. That's why you see that you don't feel your womb until the woman is pregnant. So that is what the regular fertilization process is. So what we're going to do now is that when the eggs have been produced within these earlobes now, we're not going to let them come outside because once the way the body releases the egg is that think of it that it will just rupture, it will burst, and then the egg will swim out. But that's not the case now. What is happening here is that we're going to come in and collect these eggs using something that is actually like a needle. And this is where you now hear people say, IVF is painful. Oh, it is so terrible. It cannot be done. Oh my God. Well, pain is different for everybody. So for some people it's very painful, some people it's not. But when we're collecting the eggs, you are asleep or you're not awake. So that you don't feel the pain. We just go in, use our needle, suck them out and move on. That's what we usually would do. And some people will argue that, oh, if the woman really want time, but the man really want time, not go talk about the pain, you go through anything. But pain is different. Pain is different. But it's not really so, yeah. It's different, shall decide what you can deal with. Move on. So for the oocyte retrieval and the egg collection, we collect the eggs from the woman's body, then take them to the lab, collect the man's sperm as well. And when it's there now, we allow them to fertilize, come together, and start the process whereby the baby starts developing. Okay. What this means is that the day where we're collecting the egg now is also the day where we're collecting the sperm. So the eggs are collected, the semen are collected, they are allowed to mingle and jingle, and then fertilization happens. And we'll move on from that point to step 7. So step 7 now is incubation. Remember, we can actually compress this into like 4 steps. So it's just because I want you to understand every segment of it. That's why that has been expanded into this kind of step. Step 7 now is the incubation, which I've already explained before, even though I not really give it this in when I was explaining that egg collection. So incubation, we collect the egg, we collect the sperm, we put them together, they form a baby, and we allow it to grow for about 3 to 5 days. Usually it depends. Most times people prepare the 5 embryo per transfer, or the 3. Your clinic will navigate what they want to do for you on that point. Then we'll go to the 8th point, which is embryo transfer. What that one means is, remember I said that we're going to use embryos like babies. So embryo is a baby, essentially. It's just the term that we use for it medically. What happens is after we have allowed them grow, what we try to do is to use the best growing ones. So let's say we have 8 embryos developing and we want to transfer. I'm not just going to pick any random one. We're going to transfer all the best 3 or 2 or 1. Depends. Countries have regulations of simply one transfer, that one embryo that can be transferred. Some say 2, some say 3, some simply don't care. But it all depends. But there are partners within the nation. You cannot transfer more than 3 within Nigeria because their partners there is a regulatory process for these things as well. Those people that are planning to get 7, we can transfer 7 or 5 or 6. That's what a lighter note do. So there's something that came to my mind when we were talking. What was that? Okay. All right. So the idea is okay. Older women, yes, can tend to handle more multiple pregnancy, but we also worry of multiple pregnancies in the sense that the more the number of babies the more complex the pregnancy tends to become, and the more risk you're putting the mother at. So, but of course, with IVF, we tend to have more than one baby because of the nature of the fact that we're transferring multiple embryos sometimes, depending on what's actually going on in that particular point. Then, okay, step nine, the last 2 weeks. The last 2 weeks. After you've gone through all of these things, after every form of testing, evaluation, stimulation, embryo, site retrieval has happened, and the baby has been transferred back into your womb. Because that is what it is. After incubation, then embryo transfer. So you incubate and you transfer the babies back into the womb. You choose the best, all right? And after that has actually occurred, the next thing is to come to the last 2 weeks. The last 2 weeks is a time of waiting, it's a waiting period and can be one of the most excruciating periods upon the face of the earth. Reason being that it's the point where you wait before you can do a pregnancy test. Ideally, it's also be able to show up from the 10th day, though, but waiting 14 days to be more to be sure, right? Which is what you want for us, that we're doing things in a way that is sure for you, the way that allows us to understand that what you are going through is not just about money, it's about the pain, the emotions, the trust that is required to get through these things. And we're here for you in our way, in our best, the best way that we can be. So within these last 2 weeks now, the embryos have been transferred, the babies have been transferred, and you go home. So people say, oh, after if you do IVF, you can't move around or something. It's not true. We even have the saying that these precautions I want you to take after IVF are the same precautions as a woman that just had intercourse with her husband and has likely gotten pregnant. Nothing special about it. What's usually just this. So after the embryos have been transferred, we are wait for the 2 weeks, the 10 days if you want to, but we usually wait 2 weeks. We'll do a test to now see if your body has taken the pregnancy or not. If your body has taken the baby, then we'll monitor again, keep on monitoring. You're registered for antenatal or follow up depending on what your clinic is using. And after 2 weeks, we'll come back to test and see if the woman has taken in, and then we'll monitor from there to see how many babies you're taking in and all of those things as well. During the waiting period, you don't necessarily need to get off work. Even beyond that, you do your regular life. We don't expect you to be fighting in the street or something like that, but we do expect that you go about your regular life. You can go to your school, you can go to your church, you can go to your business if it's not too strenuous at all. Whatever it may be, you find a way to navigate it. But it's not you're not an egg now. It's like regular pregnancy. You need to do your things, but do them with wisdom, right? That's how you navigate it.
If you like this video and you want more information about fertility, IVF, babies, surrogacy, IUI, and many other fertility procedures as well as medical issues, kindly subscribe, share, and like this video for more.
Then the step 10 here, I put the pregnancy test as step 10. So after 2 weeks, you come in, you have the pregnancy test. It's not an easy thing to get pregnancy test sometimes. And for some people, it's a negative thing, it's not positive. And it can be really terrible, devastating, and painful. So my heart goes out to every one of you here that has experienced something like that. We'll do our best to give you the best results. Then after that is done, the pregnancy begins and antenatal. There's one common conversation that may also come up, which it's not categorized here, but what happens when you're pregnant, antenatal begins for some clinics, some they just say wait to 12 weeks, wait to 20 weeks, and just keep on seeing you are not really quite sure. Common management is actually the goal and the best way. So that's what it is. So okay, as the pregnancy continues, with that when you be scanned to know how many babies you accepted. With that, we have come to the end of the steps of IVF, just to for that area. Then we're going over next to the steps of IUI/timed intercourse. So for this one, remember what I said before. The beginning steps are similar: consultation, examination, evaluation are one. Then you now go into the other thing down to testing. You get so consultation, testing, result review. Those are the same things. Then you now come to number 4. Step 4, which is drugs, may or may not be used in an IUI. So let's start with the beginning of everything. I think we've discussed ovulation dates, yes. So cycle and meeting frequently, right? So then we'll go to IUI. IUI means intrauterine insemination, and what IUI actually is maybe there's a problem with the semen, maybe there's a problem with the transport system, and the doctor places some medication to try and support and help and see how that goes, right? So that's really what happens. But in the IUI situation, there are two things we are looking at. One of them is, do we want to do an IUI that involves stimulation, will make the woman get stimulated when they're young? IUI is done for a younger person. Some people say not above 35, some will say 30. So we want to know if it's coming from our end, an end whereby there's a mechanical problem. They will not see how we can solve it. If the semen is poor and it needs some boosting, we see how we can boost it, right? So that's what's happening. But what we're not doing in IUI is that we're collecting that sperm now, watching it in social media, and the strongest and the best ones are taken out to be injected directly into the womb. So we don't want the sperm now to be fighting through cervical mucus, to fight through whatever is in the vagina. We don't want any of this. We want it to go straight to the eggs and minister to them. And they understood and came out because they knew that that was not their territory. So for IUI, what we're trying to do now is, when we're doing this, we can also give drugs for the stimulation. And when we have the drugs, we follow up with the date and they can now meet on that particular point. Follicular tracking, this is IUI. Okay, follicular tracking means that we are likely thinking that there is no issue, and we just track to see if the woman is producing follicles. Not even no issue, there are issues that you track still to see if the woman is about experiencing menopause and all those things. So we move from there. Mm, so for IUI, after that, after they have been given medications to help improve in maximize egg production, then can now. So time sex. So for time sex, it can be stimulated or not stimulated, just like the same way it is for the IUI. Some people for IUI will give them medication to stimulate, others they don't go for that. They prefer just natural, they just inject experiment to it. But for this time whereby you may for IUI you may have tried drugs, IUI is not working, then you can now start discussing other possible options that actually exist. All right, so I'm hoping to be able to see. Okay, all right, so let's begin. IVF and failure. Okay, so we're done with the steps of IVF now. We're moving on to a number of other things. We still have a long way to go, maybe a short way, depending on how you look at it. So, let's start with, okay, let me state egg donation IVF steps. Then the bonus topics are egg donation steps, as if you are, if IVF fails, IVF is not 50-50, the success rates, truth about the success rates, truth about IVF success rates, surrogacy, IUI, okay, timed intercourse, um, timed intercourse, follicular tracking, hormonal imbalance, drugs use, low sperm count, oligo, then azoospermia, blocked tubes, menopause, blocked tubes, menopause, gender selection, AS plus AS. So this is, you are seeing me generate right some of the common questions that come up, right? In the time selection, yes, menopause. Which other ones are the common ones that come on? I just want to answer as many as come to mind, since we're right here. We might as well just do that, right? So let's just answer that. Anyway, any other ones that come to mind, we're going to navigate. Navigate them. Okay, duration of IVF. Duration of IVF. IVF from a distance. This is UK, US, different states. Walking after IVF, you have to be admitted. Admitted. Wow. Wolves. All right, so let's go. Let's dive right into it. So for egg donation IVF stuff, we may be a bit fast for some of these because as you can see, they're a number, and I really want to get through them for you so that you can get as much information. I did. What the goal is by the time you are done with this video, you have a lot of answers to the questions that you have about IVF. So much so that you no longer have to seek more information, but you can directly move into the next point. So for head donut, what usually happens is we begin with the first one. You come for your consultation step one. Remember, step 1 to 3 are usually common. Consultation, testing, result review. After that is done, then the next step is to match a donor to you. Depending on where you are, which nation you are, the hospital you are using, the laws regarding the area, some other factors that may be, the process of donor matching may vary. Some areas you can do donor to donor matching where you see the pictures of the donor, you see a donor database and all that, then you select based on what you want. You can see select also based on where the patient is at that, where the donor is at that point. Maybe the donor is a medical professional, the donor has tertiary education, the donor is a high achiever, all of those things. You use these things and as parameters to select. Sometimes it may not be readily available, so that may not be what you want because in some areas you don't have access to your donor source. So say sometimes it is that you give your specifications. So I want somebody that is tall, somebody that is fair, somebody that has tertiary education, somebody that does not have this, does not have that, whatever it may be, and then they get you your donor. So it could be a double-blind procedure where you don't meet your donor does not meet you. Neither of you know one another. The clinic is the middle point and the interface between you and your donor. Then that is it. So you just say donor matching is step one. When donors are matched, what essentially is happening is, and what essentially has or is going to happen, depending on which direction your clinic is going with it, is that there'll be a complete history and medical screening of the donor. So it's not just getting someone that meets your criteria, it's screening the donor and seeing that that donor is fit and is okay for you to use the eggs because we don't want the situation whereby you get the donated egg and that donated egg becomes a problem. So your donor is then placed on. Remember what we were saying earlier. If not, there should be a video somewhere on the channel currently or coming up. Well, I the one I don't know what the timeline will be when you're saying this. Where we talk about the process of IVF, and we're talking about if you are doing a donor egg IVF, what happens is the donor is the one that is undergoing that phase of stimulation. The donor is the one undergoing that phase of stimulation. What that means is she is the one that receives the medication that are meant to help her produce a lot of eggs. So your womb is prepared to receive the baby. We regulate your cycle and that cycle as well. That will get some form of synchronicity. And then when the eggs are retrieved and taken to the lab, fertilized with the semen that we are using, yours or a donor, depending on what the situation may be, we bring it back and transfer it into your womb. So that's what happens. Then so that's pretty much it. After they have been taken, the babies have developed for a number of days, transfer back into you. They will get back to the 2 weeks pregnancy test to see if your body, your womb, your uterus, your endometrial lining was able to allow implantation, which means that your body accept the babies to use other non-medical terms. And once you are pregnant, we know that we're commencing that phase and continue monitoring from there. Yeah. So, if IVF fails, what next? If IVF fails, what next? The thing is, so IVF, the reason why I smile is usually, they'll tell you when you're making this, you try to be as optimized as possible, don't roll your eyes and all this, but you're seeing it in real time. I'm trying to give you the information in real time. So, you see some of those machinations, right? So, what is this? Okay. IVF, unfortunately, worldwide is not at 100% success rate. In fact, IVF is greatly affected by the fertility and the fertility of the human population, the underlying statistics that we have as humans, which is all generally not being a particularly fertile species. So what goes on is that sometimes after doing everything right, procedure perfect, the process is beautiful, medications optimal, timing and predictions wonderful, you may still get a failure. It is a reality. And I say this knowing that it's uncomfortable to hear. I say this knowing that the best thing that what you would like to hear from me is that it's 100% sure once we are the ones working with you, we ensure that you get success no matter what, you're going to be all right. It is not so. It is not so. Uh, it's not easy to deal with the negative results. But the thing is, you have to take the chance. So what we do is we optimize our own processes, use processes that have worked for us. We try to do consistent internal reviews or keep up to date with the advances in the world, use the medications that are the best that we can find that we keep on importing regardless of the cost. So it's something that we usually the conversation comes up like, can you get a discount on the cost of IVF? Except during discounted periods, which sometimes run, it's not really something that will gravitate to us. Let me just answer that question. Reason being that at the point in time when in Nigeria there were a lot of economic turmoil and uncertainty, and the inflation rate was rising steadily, consistently, at at a very rapid and exponential pace, day in, day out. You will go to bed the morning, there's something costs this, by evening, by the next day, when you wake up, it is a different cost. And we have to have an internal review. Do we keep on using the drugs we are using because they are being imported from the companies? Do we keep on using medications that are the best, that we know that has given us results? Or do we opt for lower expensive options, less expensive options, and all those things? And suffice it to say, we did, because we are, like I tell you, our science is not magic chance. And we did do a test to ascertain that we realized that we preferred to stick with what we know works and what the best and more expensive. Reason being that it's better for us to give it the best possible chance at a more expensive point and give you that chance, and we'll try it and know that okay, maybe it doesn't work, but it's not that it does not work because the process was flawed, but because of the fact that it's simply what we found at that point, right? Knowing that we give you the best chance rather than trying to cut costs and now reducing the best of chances possibly, and then now having to redo it again the second time. With the question now being, was it the process that was the problem, the medications, or was it simply that we do not have full control of the human body as it is? So those are some of the things. But this is what a failed IVF is. Let's dive into the meat of the matter. If IVF fails, what next? What does it mean? If IVF failure, let's just say what's an IVF failure. So IVF failure. So we started with the point that IVF failure exists. It happens. And you hear more about IVF failure than you will hear about IVF success, because it's just the nature of life. More negative things travel more than the positive things. People that do IVF may not necessarily come online and say, oh, we did this or we did that. They just go home, they do their baby dedications, they do their ceremonies, they do their naming ceremonies, they do their parties, whatever they may decide to do. I may not come back to say that this is what I did right, because they got what they want. But the person that does not get success is highly aggrieved. Understandably so. It's an expensive procedure. It's, in fact, the true cost of IVF is not even in the financial cost. It's an emotional cost. And after going through this, you don't have your success. I will be enraged. I would be pissed. I will be livid. And no matter what would have been explained to me, when it will come to that point and I do a pregnancy test and I find out that it is negative, I would definitely not be happy, because there's no way to set myself up to be happy about that kind of information. So that's why you see a lot of the reviews that you may see, you see a lot of negative reviews going around. But if you do want to also get the full objective view, look for people that have IVF success and talk to them. See what they'll tell you. They'll tell you to go ahead. They will tell you, I think there's a lady that's, well, okay, especially we'll post some videos if we are, of course, with the consent of the patient, if they are willing to have conversations, to like let you know that this is what they have, this is their experience with the whole IVF process. And so you can see some also positive statement. We'll have messages of that. So I'll speak to my media team. They'll see if they can compile some of the messages that they have with consent from the patients and see if we can also share them with you. So you see what this does for families. These families that are becoming complete, are becoming joyous, are becoming happy because of IVF. So the chances of failure forever will exist. Maybe not forever, because we're hoping to get 100%. So point of ideas. Personally, that is what I'm looking forward to. Consistent 100% results, right? Because not like sometimes you get 100% in a particular cycle or something. Maybe you did for especially smaller cycles of smaller batches of 35% doing IVF at a particular period of time. Yeah, but that does not mean you're getting 100%. So do not be deceived. When someone says, "Oh, they're having 100% success," it may be that they had it in one segment of time where they did for a couple of patients. Maybe that's just what it was at that time. I'm not saying that they are concerned that if there's a hospital that is having 100% IVF success today, I would send all of the patients that we have there. Forget about it. I will send everybody there to go and get their success. So it doesn't exist in the world, right? That is why, because that is the inherent nature of the procedure. But the procedure is a helpful one that has brought successes, and as such, should be celebrated. Sometimes you take the chance. It does not mean that you will definitely win, but it gives you the chance of success, and so we say go for it. And in the grand thing, sometimes they feel that IVF is not the waste. Because if you do an IVF today for prevention and there's no success, one thing that it has done is that we have hormonally placed your body at a better place, think of it as in a pregnancy state. And oftentimes, once we do a repeat after we can say wait as long as you're comfortable coming back. So we may say usually one cycle is enough for us, but it depends on you. When once you have one menstrual flow beyond the one that we have given the medication that you were on, then we can go back in for a trial, because you're no longer starting from in regards to what is in my it builds upon one another. That's just what it is. It builds upon one another. And there have been situations whereby women that are actually having maybe unexplained infertility, like if you remember, okay, we talked about the causes of infertility at some point, and in somewhere it should be somewhere on the channel, hopefully, or within on that video. I'll see if it's something we can also highlight. There's so many things to highlight, so I will be able to highlight some. Some we may not be able to really pick up in the moment, but over time they should be picked up. Okay, yeah. So we say there's 30% causes from males, 30% from female, 30% is a mixed factor, male and female factors, and about 10% that comes in from unexplained infertility. So at a time whereby everything is fine, the semen analysis is good, even though maybe not so great, the tubes maybe one of them is working instead of two, or some of those things, um and some of these things are going on. You can see that if and it has happened, the couple may do IVF and they would now go back, and why maybe the IVF fails, they get pregnant in between while preparing for the next one, because the body is already in a state that makes it receptive for pregnancy. So that is one advantage of it. Second thing is that we were talking about points where IVF fail, points where IVF fail before now, and one of them is the most common one is after transfer. You get to the point of IVF egg retrieval, the eggs is retrieved, embryos are developing, and they are transferred back, and then the body does not take them up. So that is one of the most common points. That is that it could be. Then on that point that could fail is even in the preparation process, that stimulation process that we are talking about, where the woman is on drugs and being prepared. It's also possible that our body does not take the drugs, and our body does not respond properly to the drugs in the way we want. And it happens like that sometimes. Sometimes the first cycle does not have proper response, and you now have to pause that cycle, and pause that cycle it's a cycle, sorry. So pause that cycle and go into the next point and wait, then you come back again. Usually that second build up can also be better than the first and give you a better the idea is just everything builds up on one another. The failed IVF is not a waste. It's a chance that you are taking. It's a chance that you are taking, and that's the most important thing. It's a chance that you are taking. Rather than sitting and accepting defeat, you are taking a chance at doing something, and it is very good to do that. Um, so just remember that IVF is such IVF is a way of saying I do not accept this verdict of no pregnancy. I do not accept this verdict of I cannot have a child of my own. And there's no way to get pregnant. There are options, and I am bold, I am brave, I am taking them. And I have refused to be put down. And I will take a chance at my pregnancy. And that's what it is. I have refused to be put down. I will take a shot, even if I'm not sure what it's going to be, because I take my chances. And you never really know what you get. See, this is what I tell you. Close your eyes right now. Close your eyes right now. Imagine your pregnancy. You should keep your eyes closed. Imagine yourself being pregnant. Imagine that feeling of your stomach being full, being big, getting bigger. You're feeling, you are complaining all the complaints that are there. Oh my God, this pregnancy, oh, it's making me eat too much. It's making me sleep. Oh, I woke up and I'm feeling nauseous. I'm vomiting everywhere. Imagine yourself. You can give those complaints as well. Think about your antenatal visit. Ah, they have given me that 1 week again, and I wanted 2 weeks. So being on the medications, oh, routine medications, oh, and this swallowing drug every day. I'm tired. I don't tire. Imagine those your weird cravings that come that will now come up. Ah, I want to eat this. I want to eat that from here, from the next town, from the next street, from this particular woman. It can be you. Imagine your delivery, the time whereby you are going through the labor pain, and if that's on that point, if you are going through the labor pain, let's put it that. Although for most IVF babies we opt for cesarean section, then imagine your baby crying. That noise, okay, that's a terrible, it's a terrible rendition of it, but the crying that happens, right? Imagine those days. Imagine your baby making all the fuss, running around the house, their first graduation, when they finally go to school, university, and you walking them down the aisle when they get married. It is all possible. Don't you think this is worth taking a chance on? You can open your eyes now if your eyes are still closed. Don't you think this is worth taking a chance on? I do. That's why we do what we do. I think it's worth taking a chance on. It's a beautiful thing that IVF can feel. Yes, it can, but it can also work. And that is where our focus is. So the next point is IVF is not 50-50, which is something that you probably hear. Yes, this is about IVF success rate, right? Everywhere you go, yeah, IVF is 50-50, IVF is 50-50, IVF is 50-50. Or you even hear, oh, most of it fails, so that's it. But it's not exactly so. In the sense that IVF success rate varies across ages, across conditions, and across individuals. So even when we give the full estimate of IVF success, we say that, oh, people below the age of 35 can have a 40 to 55, 60% maybe chance of success. It's a very generic response, because within those ages, what are the causes? Are they having blocked tubes? Are they having hormonal imbalance? Are they having endometriosis? Are they having, okay, that reminds me, adenomyosis? Adenomyosis? Is it a low sperm count situation? You know, all of those things. So when you look at this, you realize that it is different for everybody. You can be told that a woman that is 50 has a low chance of getting pregnant in IVF if she does not use donor eggs, and somebody does it and gets pregnant in one trial, sharp, sharp, twins or triplets. So she got 100% right. Did she not? Because in her case, she did once, got pregnant, and okay, when she even gets twins or triplets, do we say she has 200 or 300% now? Depends on how you look at it, right? But the point is, it's really individualistic, and there's no way anybody can categorically tell you what your chances are until you do it. But we're going to use informed decisions. We're going to make informed guesses. So we're going to take informed chances. So we know that at the age of 50 or at the point of menopause, we are no longer going to be going towards stimulating you to produce the eggs that are necessary for the procedure. However, we can actually get donor eggs that will increase your chance and know that it's possible for you to get it once. So that is what it is, right? That is what it is that we're looking at, and we're saying take your chance and go through it. You don't really know what it is. So um that is what the point is. That in a and this let me make an example of two women that came in from Benin City, but we are traveling down to closest center for them was Worry. One of them were traveling down to Athens at the time of this video. Maybe by the other time it might be different, but they're traveling down and follow the same processes. And one of them got pregnant, one did not. One of them got pregnant, one did not. That's just to tell you the difference, and they're about the same age. So it is different. It can be very very varied. And we've had patients that travel from outside the country and go back and they're successful. And somebody is coming from the next street and they don't get their success because it varies. And I remember a group of 10 women that got pregnant in our facility that we studied. We were trying to see what's went on with their procedures and how those things. And 8 of these women got pregnant in their first attempt. 2, it was their second attempt that they got pregnant. If I recall correctly, maybe there was one of them that was a third attempt or so. And of these women, it was only 2 of them that were under the age of 30. 6 out of these women were between the ages of 35 to 45 plus. When I say 45 plus, meaning 50, 51, they're also there. A patient of them, one of the ladies among them was about 55 or 56. So nobody can really say what your success rate is. So a lot of the negative news is what you hear on social media. IVF is a story of miracles. It's a story of lost hope being restored. It's a point of families that had no way out being given a way out, being given a second chance at this game, being a second chance, giving a second chance at this journey, being a second chance to get pregnant as well. So it could be multiple babies on your first trial. What did you want to find out at? It's up to you. All right. So the next thing we're looking at now, let's see. The time sexual intercourse, let's just say that time sexual intercourse simply refers to telling you the time to meet. So what we do there is we try to follow you up to ascertain when your ovulation is. There are two ways to do it. We can just do it verbally and teach you how to calculate your ovulation, which I've calculated in an earlier video, and because of time we won't get back to it. So try to link that up if you can here. Then we try to say, okay, ovulation is usually 14 days before the next cycle begins. We make our calculations there. Ultimately, if we can use ovulation trackers or use tests in the lab, we do those things. And it's also where follicular tracking comes under, but we'll leave follicular tracking a little bit before we go into it. So we do these things and they'll tell you that, okay, it's very likely that on so and so date, you are going to be ovulating. So because of that, you should meet your husband around this period regularly. And that's not something you need to get pregnant. And let's move to follicular tracking. Follicular tracking still follows the same basic principles. We are trying to ascertain when the follicles are going to be released. Just that at this point in time, we usually will be using scan to analyze. We're scanning you consistently on days, day 2, day 10, day 14, day 12, day 12, day 14, looking at the size of the follicle, trying to ascertain. And I have somebody now, interestingly, they named their baby after me. And it's quite interesting because they were having issues getting pregnant, but what they did was follicular tracking. That's what it took. So at the point they found out that they were beautiful looking follicles developing on scan. So the follicles were nice. We had the dominant follicle and even about 3 supporting follicles here there at the time. So they went and had their meet up, and she's pregnant today. About 3 months gone at this point. About 3 months gone at this point. So that is what follicular tracking is, and that is an option that can actually be followed. So time intercourse follicular tracking. Sometimes we can now move off a step further and do stimulation where we place people on medications and to stimulate more egg production for them that month. That when they meet at the point of ovulation, there are more eggs that are there that are likely to cause them to get pregnant. It also increases the possibilities of getting a twin or triplet around that time though. So there's that. So let's say getting twins and triplets. Is that really a topic? Let's just get into it a bit and let's just say something about it. One thing you should know is that there are more occurrences of twins and triplets and across the older ages of women. And like I said before, remember that the way the quality of the eggs were when you're younger is quite different from when you are older. So the older you get, the more likely it is that twinning would occur. Then beyond that, there are also locations that you have a lot of twins. And the twin capital of the world should be a city in Oyo. I'm trying to remember the name of the city. It's escaping me at this point. If I can pick it up, maybe we would highlight it. And almost every family has twins there. That's been tied to maybe the yam that they eat, chemicals in the yam, their diet, and all those things and all those things. But the point is, somebody from that village is going to have a higher chance of getting a twin pregnancy than most people outside of the village. Somebody eating that yam, if that yam is something you can get your hands on, is going to have more chance than somebody that isn't. So there are some of these genetic factors, location factors that come into twinning. But when people ask this question, what they are trying to ask is, how can you, doctor, help me to get twins? And it's not something that will gravitate towards doing because it's not legally wrong, ethically wrong, but it's not usually something we would delve into. You want to get twins, and they will come up and say, "Oh, let's place your medications for that." It is not especially if you have kids. No, it's not something that we'll do. But we do have medications that we use to stimulate egg production. So, theoretically speaking, one can use those medications, boost the egg production, and the likelihood of when a woman meets, they get twins. However, one of the more reliable ways would be IVF itself, because in IVF, within my nation, may not be the same it's not the same in the UK, I'm sure, and some other countries, is that we can transfer up to 3 embryos and that now increases the chance of twinning. But the thing is that the body is a very funny machine in the sense that I remember a couple that had was it quadruplets? That couple had what? So they had okay. It was for that couple. It was twins. So what was actually happened was it was three embryos that were transferred for her. The body accepted two, and the two now within the two, one of them split to get triplets. But there have also been cases where the body only accepted one, and I recall a case like that. They had two girls and a boy. I mean, no, two boys and a girl. Yeah, where it was one embryo that was accepted but split into three, and the person got pregnant. I can also recall a patient that had quadruplets, had two embryos transferred, if I recall correctly, and she had uh, quadruplets at the end of the day because the body has its own role to play. It does its own thing sometimes, and we can only try to guide it in a way into that light. Another way is in families where this ties back to the genetic. In families where they have a lot of twins, you're likely to have twins there. Although remember that studies have shown that it is tied to the female aspect. So if a man is a twin, his brother is a twin, his father is a twin, everybody in his family is a twin. It does not generally affect the chances of getting twins. But if a lady is a twin, her mother is a twin, and there are a lot of twins in her family, her mother gave birth to twins, all those things, she has a higher chance of getting pregnant with twins because it's tied to the female aspect. The closer the linkage, the better. So mother, sister, those kind of things are actually what will affect the possibility of getting twins. All right, so let's move on to hormonal imbalance. Hormonal imbalance is a general term, and it can refer to a number of things, right? That we're actually looking at. So it's after hormonal review, you do an hormonal workup, an hormonal assay that is should be part of your fertility workup or your fertility screening. Then you ascertain what hormone is at fault, is skewed, and then we'll see how we can correct it. One of the more common culprits is prolactin. So you hear it hyperprolactinemia. So women may say, I'm not breastfeeding, I'm not pregnant, not nothing, and I'm seeing breast coming out of my nipples, right? And it's possible for that to happen without there being any medical condition. Yeah, maybe the hormones are working due to certain periods. For a lady of reproductive age, if there's someone that's consistently suckling on it, you are likely to have production because there's a microenzyme reflex the body responds to when a baby is born and the woman has not started expressing milk. The way the body gets the signal to start releasing it is when the baby suckles. So if a man were to be doing that around that time, where I'm not saying you shouldn't do your thing, but is that if it's happening around that time, it can happen frequently, even without her being pregnant. It's possible for her. In fact, we know that a women of reproductive age who are nursing a baby, maybe for their sister or for someone else, and allow the baby to suckle frequently will start producing milk because the body follows that signal to release prolactin and signal the release of milk. So, for example, that's just hyperprolactinemia, and that symptom that comes in, as well as maybe irregularities in menstruation, the dates of menstruation are not balanced, things are wonky. All of those things can actually come into play. And I recall a couple that wanted to that I'll tell it in two dimensions. A couple that had issues with hyperprolactinemia, and what we did was to place them on medications. Usually, one of the common options are bromocriptine and the other machinations around it, right? And they got pregnant within about 2 months. They didn't need to do IVF. There's another couple, however, that she was placed on the prolactin. She did not get pregnant within 3 months. We saw that the levels were normal. So she went in for a procedure and she got pregnant. So different stories for different people, different stroke for different folks. It's just what it may be sometimes. So hormonal imbalance depends on which hormone we are looking at. And we can now see how we are going to step in and help out in those situations. Sometimes medications alone are enough. At other times, what happens is you need to do medications and then still do a procedure to get the pregnancy that you are seeking. The point is be open and willing to go from step to step. Doctors are not magicians, we are not soothsayers, we are not miracle workers. What we are scientists. That's what we are. So low sperm count. What happens in the case of low sperm count is that sometimes you see when it comes to low sperm count, there are a lot of factors that we're actually looking into. We're looking at the possibility of saying, what are the parameters that are low? Some of them may be able to get placed on certain medications. There are various classes of medications that will go with. Of course, we start with lifestyle is one of the first. For somewhere around the channel, there's also a video about diet. lifestyle changes are one of the most important things you can do. So no smoking, no alcohol, no basically plant-based diet is good. Mediterranean diet, a lot of fruits, lots of vegetables, lots of white meats, lots of healthy exercise. Those things are very, very good because they also help us. So that is usually step one for a lot of things, lifestyle modification. In fact, even down to, this also brings me back to PCOS and weight. So usually when women are trying to get pregnant, we advise them to lose weight as well, especially for ladies that have PCOS, polycystic ovarian syndrome, or PCOD, polycystic ovarian disease, whichever one it is that you are navigating with. And whichever one is called, you are told that you have, whichever name is given, they are the same family. So what happens is sometimes the losing of weight can really place. I have patients that when they gain weight, their periods get wonky. When they come back to their normal body weight, so a smaller body weight, their periods regularizes, because that weight gain and weight loss can also affect the periods of the lady. So essentially, what it is that for low sperm count, the first point there that actually would help is lifestyle modification. So if the man is smoking a lot, he's taking a lot of alcohol, he's doing a lot of unhealthy lifestyles, doing a lot of tight boxers, which we don't recommend. Some here we call it condom boxers, but it's not really that in the name. That is in the name. Okay, let's just focus. That's in the name, but we find that the testicles are supposed to be regular. They're outside the body because they're supposed to be responding to the heat of the area. So when it's colder, they come close to the body to be warmer. When it's hotter, they drop away from the body heat and drooping so that they can be colder. But when you wear those boxers, you put them in a consistently hot position, and that is something that we don't advise. So for those lifestyle modifications are step one if there's low sperm count. So beyond that, we can also place some medications. Different classes of medications exist. Sometimes vitamins A are what we are looking at, as simple as that. Other times we are looking at more hormonal medications and whatever name they may be, and using those ones for the patient. So we try one, doesn't work over about 2 to 3 months. The best evidence of it working is pregnancy. So we try it. If it works, we know that has worked. If it doesn't, we'll go to the next option, even up to an IUI where we'll wash the sperm with it, special chemicals, get the strongest and the best one, so suck them out into a tube, into a pipette, so to say, or let me use that word, okay, and you are injecting into the woman's womb directly. Those are options, but an IVF is also an option where we do an IVF. Within the IVF, we can do a regular IVF where the egg and the sperm are just placed together and allowed to traditionally fertilize themselves. But there are times whereby this sperm is not so good. You have to do what we call ICSI, that is ICSI, intracytospermic sperm injection, which means we use special procedures to collect the healthy looking sperm that have been looked at under highly magnified lenses. We look at them and take them out and then inject it directly into the egg, so they don't have to be swimming around and trying to penetrate themselves, maybe because we feel like they're not strong enough, they're not looking good enough, and we put it inside and cause fertilization to happen and move from that point. Sometimes, though, we have complete azoospermia. When we have azoospermia, what azoospermia is referring to is that there's no semen at all. There's no sperm there's no sperm within the semen that the person has produced. And what that now means is that there's no sperm within the semen. What that now means is that we now have to find out what the options are. Sometimes there are causes. The best option is one of the best times when we find out there's an obstructive cause. So the person is producing sperm and producing semen, but there's something obstructing the duct, and that's what we have to go in and extract. So that way, it's testicular sperm extraction comes into it. So tessi, whichever word is used for in your place. Um, um, Extract to collect the sperm from there and use. But sometimes it is completely empty. It is not blocked. There's just nothing there, and it's not responding to any medications or any procedures. And in those cases, we now have to go with a donor sperm for the IVF to get the results that we actually seek. But the key point is that even for low sperm count, there are multiple machinations for total absence. There may be options that can help, but sometimes we have to realistically take a choice of the donor sperm as an option. Okay, IVF with block tubes, IVF with block tubes. So sometimes you may find out that the cause of all, after all the screening, we'll find out that the only issue that we have is that the tubes are blocked. So what we do in that kind of situation is the tubes don't affect IVF. There's an explanation I made earlier about the way fertilization occurs and the process. What I was saying is that this is the head, this is the ovum, these are the access points to get into the ovum, then the mouth is the entry point for the sperm. So if the access points are blocked, there's no way for the eggs to come in. But in IVF, we don't need those access points because we're taking the egg from the body, the sperm from the man, taking them in the lab and allowing them to come together to create the baby. So we can easily just bypass the tubes and get in, and we just insert them through here, through the bottom opening, and forget about this tool. So we collect the eggs and infuse it like that, and we're able to get pregnancy even if the tubes are blocked. Ideally, though, what is being equal, one tube works as, I say as well, but as well as two tubes. So if only one tube is blocked, the woman can keep on trying. But like I said before, once you have tried for a year, if you have below the age of 35, 30, and you've tried for a year, get to the hospital. Try for 2 years, for 6 months, and you are getting married, you get to the hospital. Sometimes 3 months, and you're not getting any result, get to the hospital. Now we see what we can do for you, because it's always going to be, the earlier you come around, the better it is. Okay, so essentially, let's just see how far we can go for IVF after menopause. It's actually still very possible we do IVF after menopause, in the sense that for that, but realistically speaking, what usually happens there is donor eggs. So menopause means that the eggs that the lady was born with, because a lady is born with a specific number of eggs. Also another explanation that has been, as on the channel, eggs at birth. Okay. So, and they get exhausted with each menses that comes by. And so what we do at that point in time is, once that is the case that is going on, then we have to get source for donated eggs, because if she has menopause, it means her body has exhausted that store. So we source for donated eggs, use them for the procedure for her. And we have women that are in menopause, that have been in menopause for 4 years, 5 years, and some people that are getting pregnant. Although realistically speaking, sometimes for people, we just have to opt for a surrogacy because it is the better option financially, based on what we are seeing, and all of those things. All right, all of those things. So there's that. And surrogacy. Surrogacy refers to the option where a woman does not have to carry the pregnancy by herself. And there are a number of reasons for surrogacy. Nowadays, people opt for surrogacy because they don't want to go through the stress of going pregnancy, which is fine and good if they can afford to do so. And depending on the regulations around your country and around where you are. But it's something that is becoming more in vogue. But beyond that, also, surrogacy came in as a solution. So women, maybe because of whatever issues it may be, are unable to carry the pregnancy by themselves, and as such, we need someone else to do so. So preferably if they are within younger age. One of the reasons why we say come around early, if they are within younger ages, maybe they've had multiple failed cycles, they are having underlying health conditions that make it quite dangerous for them to go IVF with IVF with DM, HTN, MS, others. Okay, so they that making it difficult for them to get pregnant. We say, okay, no problem, it's all right for not for them not to be getting pregnant. We're going to get someone else to carry the pregnancy. So usually you see two types of surrogacy. You see traditional, which is traditional surrogacy, and gestational surrogacy. So traditional surrogacy refers to where the person carrying it also donates her eggs for the procedure. So she's carrying a baby that has a genetic background, a genetic that shares genetics with her. So she is the biological mother of the baby. Let's see, don't know who is the mother, who's the parents slash mother. So she's the biological mother of the baby, and that is traditional surrogacy. But it's not something that we generally opt for across our facilities. We prefer that the surrogate mother is not genetically linked to the baby, because of the emotions of giving your baby up and all of those things, and it feels like you are selling your child and all those things. So we don't like that. So we opt for gestational surrogacy, which means that the person that is carrying this pregnancy has no genetic tie to the surrogate. So somebody that is different, right? So that they know that it is not their baby. And yes, there are legal backings, there are legal underworkings, there are documents signed, there are lawyers involved. But there's a court of public opinion, there's also the heart and what we're not unfeeling. So it can be quite difficult, more difficult to give up that kind of baby than a baby that shares your genetic imprint, than one that you know that okay, the egg is not mine. And what we even would aim for couples, especially younger couples, we want to use your egg and your sperm just as somebody else is carrying the baby for you. Maybe for whatever reasons it may be that is unable, it's impossible for you to carry for yourself, or it's not advised that you carry for yourself. So for surrogacy also goes through consultation, your testing. We're trying to understand your basic internal milieu and all those things. Then we're also now, after that is done, we get the surrogate for you, will do their matching, their screening, and all those things to ensure that will they fit what you want, especially of course genotype screening and all those things are done, preferably well full up to AA. That's what we go for. So when that after that is done, then the surrogacy process preparation begins. In surrogacy, we are preparing them. Think of it like preparing them for an IVF procedure themselves. So they are going into the consultation, the testing, the result review. They go through the stimulation for the egg production. They go through retrieval of eggs. They go through the if they are, they usually will not be the ones who have the eggs being retrieved. So maybe the eggs have been retrieved from the lady, the eggs have been retrieved from the lady, and then beyond that, you can now see that the eggs have been retrieved from the lady, the patient herself, and the after the embryos have developed, the babies have developed, they are transferred back into the woman's womb. After transferring to the woman's womb, she's still placed on medications and watched until 2 weeks after, where we now test to see if the body has taken it. Usually, surrogacy would have a higher success rate than IVF for certain ladies because by the time they are considering surrogacy, it's usually that they are getting close to menopause. So we opt for surrogacy at that point because the surrogates that we often go for are mothers that have had at least a baby and they do not use any assisted reproductive technologies, also usually within their 20s and early 30s, worst case. So because they have very good chance of success at that rate, they are likely to get more chance, better success. Then secondly, depending on the facility, for example, the clinic in Warri now, what happens is that payment for surrogacy has 2 cycles covered. So within those 2 cycles that are covered, what you are saying is if the first one fails, then another one is done after it. So there's also that factor. But cost difference can also be, if, for example, currently in this moment, as we speak, for the clinic in Warri, the cost of IVF on its own is about 2.5 million, 2.2 self, 2.5, don't know, as of today, right? As of this point where we are speaking, or whenever you're watching the video, as of this day, while I was speaking. So, but surrogacy, achieving surrogacy is about 9.6 million. So you can see the price disparity, about 4 times the actual cost. Because in surrogacy, what is actually happening is that an adult lady is being adopted to take care of carry pregnancy, to take care of feeding, accommodation, medical expenses, whatever it may be, throughout that period of time. And also, a compensation is also given as thanks because you cannot pay for it. It's really just some people are really passionate about helping others. And at times, you may even see that that passion can come into a sister wants to carry for a sister, which is good. But sometimes the sister may want to donate her egg, or a brother want to donate his semen, his sperm, or that. So we usually do not encourage such things because we've seen situations in our line of work, and we prefer that it is an independent person. That maybe something, so a family issue does not happen on one day, and you are told that you don't have a child because it's your brother that did this or another. And of course, for someone to come to do that, they have genuine care for you. But we just prefer to avoid stories that touch the heart and to avoid a lot of all these things. And that's what it is. So surrogacy, after the pregnancy test is confirmed, then the surrogate is consistently monitored up until the time of delivery. From the time of delivery, then at the point of delivery, the baby is handed over to the parents, and that is the end of it. I'll just make a note on here on the nature of delivery for IVF babies and all of those things, as reproductive technologies. Usually, especially for IVF or surrogacy, the goal, the target is often a cesarean section. And it's not because of the fact that they cannot deliver on their own, just because of the high emotional, financial, and everything cost that comes into it. That's one. Two is also the fact that we can control a cesarean section we can actually control more than we can actually control the vaginal delivery. Yeah, more than we can actually control the vaginal delivery. The cesarean section is faster, is more regulated. When the baby has to go through that canal, a lot of things can happen, even if you are monitoring. So we don't want to have to go through that. So usually we advise for cesarean. Of course, the choice is ultimately yours. But that's what we gravitate towards, and that's what we advise because it's easier and better that after everything we've gotten a success, we should take it to the very end without being taking any unnecessary risk about it. Yeah, so gender selection. Usually, this is a question that comes up a lot. Okay, let's look at a situation that happened just yesterday. A patient she reached out to me and said, okay, so she has had, so far she has two girls, and let's begin from the beginning. So I messaged her, doctor, I'm having issues. My marriage is about to fail. I need your help. Can you help me? And I'm like, okay, have you given birth before? What's going on? Because there are usually some preliminary questions we ask you, like I explained in the earlier aspect of this video where we talked about consultation. And she answered and got to the point of the fact that she has given birth before. She has two female children and she does not have a male, so her husband wants one, and that's what is causing the friction that they have. And when she mentioned that, we came to a conversation about it. And the question is, how can we help in IVF? I explained at some point earlier on about how people can try to use ovulation dates to determine the gender of their kids. Well, in this case, now that's not what we're trying to do. In IVF, what we do is we follow the initial IVF procedure, you do your consultation, then we do your test, then you come back in to review results. So consultation, questions, history, evaluation, examination to try and understand what's actually going on. For the testing, as much test as we need for you, for your husband, we do tests for both of you to ascertain what we can do and how where we can go next. And then results review. When the test results are out, we come for review of results. We go into this in the same direction of IVF, where ideally what we're trying to do now, we're going to presume that this lady is within she's below the age of 35, 40, especially that she has good health qualities or not have any health condition that prevents us from using our eggs. Then we're going to go next into stimulation. That is giving her medications for stimulation. When the eggs are ready, we'll continue monitoring. When the eggs are ready, we retrieve the eggs. After the eggs have been retrieved, we take to the laboratory where, in addition with the sperm fertilization occurs. After fertilization has occurred, then we want to transfer back into the woman's body. However, in a situation where we're doing gender selection IVF, what we're going to be doing at that point is that after the embryos have developed, we take a sample from them and we'll take them through pre-genetic screening to determine the gender of the babies. Then for our patient now, in that case, we're going to be going with sending her to do pre-genetic screening and selecting only the male embryos. Those are the ones that are going to be transferred back into the woman's body, so that if she gets pregnant from the procedure, then only the male embryos are there. Therefore, the child will definitely be only male. That is how we do PGT, and that's what can be done to determine the gender of the child, aside from the other unreliable method of trying to use the ovulation to navigate it and all of that. And using the ovulation can be whether they are using it without tracking, or they are tracking or using ovulation monitors, or the doctor is trying to stimulate ovulation or whatever method may be happening. Those are not as reliable as doing the pregnancy screening and determining the actual gender of the baby that's actually being tested. Um, I think under the platform of PGT, there are a lot of things to actually look at, in the sense that you can now start looking at, say, some ASAS couples. What are their options? Doctor, it's a common question. In fact, sometimes people even ask this before they go into the relationship. I got a call a few days ago from a younger colleague, and he wanted to ask questions about two friends that had ASAS, and they explained the situation to me. They've been together for about 4 years, and in fact, this will lead us into testing genotype before marriage. Genotype before marriage. So they had the information that the lady was AA before, but upon further evaluation and retesting, they found that she's AS, he's AS. They don't want to break up. They want to see how they can still get pregnant, which is something that happens now with fertility options that are available. It's actually possible for this kind of situation to now have pregnancy as opposed to before you say, no, 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 don't do it at all. You're taking too great a risk, right? In this case, now they have the option of getting pregnant getting pregnant. So we discussed the various options that are available. The very first one, of course, one thing that you should look at in a situation like this is that ideally when both couples are AS, then pregnancy has to be planned and assisted. In that way, you can almost definitely avoid giving birth to a child that is a sickler. In that case, that's what it is. Maybe we would still to note on calculation of what is sickle cell, what is sickle cell disease, and let's explain it briefly. And so let's just do a brief explanation here. So when you say sickle cell disease, we're talking to babies. We're talking about children that have the SS chromosome. Let's say let me put it in a way that maybe not exactly that. Let's say SS genotype. They're having SS as a genotype, and the basic information to know about genotypes is that we have AA, we have AS, we have SS. Those are genotypes. It's often confused with blood groups. Blood groups will have multiple ways of determining blood groups, but there are two major ones that we use in medicine for now. These are the two major ones that cause the most issues, and that is the ABO blood grouping system and the resource blood grouping system. So ABO blood group system is, as the name implies, we have blood group A, blood group B, blood group O. But we also have blood group AB. That's it. So essentially, these are the combinations that we are using. So for blood group A, what we're actually saying is that there's AO because it takes two, male and female. For blood group B, we're saying there's BO. For blood group AB, we're saying there's A and B. And for blood group O, we're saying there's OO. That's what we're talking about. And in looking at that, resource incompatibility, blood group incompatibility is not necessarily something that will chase down so much, although it has its role in the resource aspect of things. Ideally, somebody that is O can marry B or A or whatever they want, and it makes no matter. However, there's a resource factor nature. That's why when you do your blood group, you will see A negative, or sometimes they write it if A resource D negative, or they write it in short form A RHD positive, or any of those things. What they are saying is that the resource factor is positive or negative. So resource is where now has a bit of issue in blood grouping. I'm delineating this from the genotype now so that we'll look at it and know what we're dealing with. So in resource grouping, when the man has a positive, excuse me, sorry. In resource grouping, when a man has a positive resource group, and the lady has a negative resource group, that's when we start looking at the situation. Reason being that since the lady is inherently negative and the man is positive, if after the man has impregnated the lady and she's pregnant, if prevention that baby is not carrying, because there's no in between, either you're positive or you're negative. If the because positive always outweighs the negative effect, right? The negative is a dominant feature. So if there's a positive, then it becomes positive. If there's negative, negative will only be expressed where they are both negative. So in that case, if the baby has the positive and the mother is negative, because the body is not used to that positive resource molecule that is floating around in the bloodstream at this particular time, what happens is that when the woman is being delivered, with the blood spills, when the placenta gets abrupted, or whatever way it may be, the body gets sensitized to the fact that there is a foreign body here. That first pregnancy is not yet is affected. The first pregnancy goes on age usually. There's usually no problem. The woman delivers. This may even happen in a second pregnancy, same features, woman negative, baby positive, no issues. However, there's a time that comes here because the body has started building immunity. It's like when you get robbed in your house. So somebody comes today, steals, well, fine. You identify that the stealing occurs, but you could not get the person. The person goes, but you are making preparation. Maybe you're not too serious about it at that time. Then on the second day, somebody comes again and steals. What are you going to do? Set up security measures so that by the third time when the person is coming, you hit him with everything you have. If you're in an area where you can get licensed firearms, you are shooting down. If you're in an area where you can't, you are calling the police, you are calling vigilantes, you are setting everything in motion to ensure that robbery that was occurred twice will not occur a third time. Then what the body does, the body prepares itself in a way that it is ready for the next time. And sometimes what that means is that because of the sensitivity attack that comes on that baby while that baby is born, because of the way the baby gets pushed and attacked by the body, can get loss of that pregnancy and can lead to the death of the baby. and consequent miscarriages. Consequent miscarriages. So what we do in that case is when we know that the woman is resource negative and the man is resource positive, we would usually go for injections that will help reduce the hypersensitivity reaction of usually most of the time is rogam injections. So we use that to try and give it depends on your climb. Ideally we recommend twice. So sometime within the pregnancy and after delivery the woman receives rogam injection to help reduce that sensitization reaction that is going to be developed so that in subsequent pregnancy our body does not attack the baby. That's what we'll do. So this is just a brief overview of ABO blood grouping system and resource blood grouping system, which is now different from the genotype. Genotype is a different thing. It's the gene type. Look at it like that. So in the gene type now we have AA, AS, SS. There's a school of thought that says that the SS genotype actually developed from within the African setting to help combat the effect of malaria or some other things around the area. So the body was noticing that AA was getting really sick and decided that okay, let's cut down on AA and let's go for something else. So the body tried to make something that would be resistant to the malaria parasite, and that was brought in SS. So in trying to set up SS now, ideally the optimum one would be AS. The AS person is not as permissible to malaria infections, but they don't fall as sickly as the SS situation. However, now because there's an S, a sickling cell, it means that sometimes which is what happens in the SS scenario, what happens is sometimes when there are extreme stressors, when there's dehydration, when there's tiredness, when there's even the malaria itself, the sickness and whatever it may be, instead of the red blood cells to flow freely through the vessels, they get sickled up. They get clumped together and clog vessels. That's why you see the symptoms they have. Pain crisis because think of it as the bones being clogged. You can have hypomolysis crisis because the body is breaking down the red blood cells at a rapid rate because they are friable. They can have even priapism where there's an erection that stays on because it is within the cavernosus. Oh, okay, let me use within the pipes, the tubing of the within the tubing of the manhood, right? So it keeps it like that. Those are some of the reasons why those systems come up. That's why I see them being told to take a lot of water, to be on their regular supplements, to be on preventive therapy for malaria, and all of those other machinations that are being carried out to reduce the rate of these things happening. So when a couple has AS, we usually will advise them not to get married. Reason being that this is now coming to the calculation of genotype compatibility. So within genotype, when you have ASS, when the way the body works is that there are two parameters there. The father has A and S, the mother has A and S. Also, the father has A and A, the mother has A and S. So every time that the pregnancy occurs, the father gives one, and then the mother gives the other. So they come together to form what the baby has. So that's what you have. That's what I have. I am AA. So what has happened is that I got an A from my mother, I got an A from my father, and they are come together, and I got AA. That's what has happened here. In this situation, what it means is, as I am AA, if I am to be merging with an AS individual, I can only give A because all I have is A, but she can give an A and an S. So if my A meets her A, the baby may have an AA, but if that's not what happens, then my A can meet her S and the baby has an AS. Now what happens? In A situation, the A can meet the A and they have an AA, but the ladies A and the males A can also meet S because they both have S to share. So there are two chances of that A meeting S. It's better explained in a pictogram in a pictorial format. If you can get one, we'll put that one for you here, or release it without it, just whichever way is faster for us. So that I want to get the information as soon as possible. You can easily check it online. AS or genotype diagram, genotype compatibility diagram. Then we have A that can merge with either of the S, or you can merge with his own self A. So you can have AS, or AA. But we now have an S that can also merge with an S, an SS. So when two AS are coming together, they can have, and there are four possibilities in that scenario. An AA situation, A measuring with an A. They have two situations whereby the A's can measure with an S. So you have AS, and then they have the possibility of SS. So because of that possibility, that's why we usually would advise that couples that are of the same genotype do not get married. And it's reset in every pregnancy. So it can't be that you add an SS in the first one, therefore the next one you're going to have an AS, and an AA. It resets. Some people have it, some people are lucky with it. I recall a patient that had 10 children, and it was the very last child and only the last child among all the children that was a sickler. Reasoning mean, although it's not with this era of awareness, they weren't aware that they were carriers of the sickle gene in the first place. That what AS are. They were not aware of that. So they got in and got married. They gave birth to all their children. It was the last one that started having some symptoms. And that's when, with the symptoms that he was having, and I was told about, realized that, okay, this is a sickle cell disease patient. And based on that, baby was treated accordingly. Yes. Then I recall another couple that also had that, they don't have 10 children, they had 3 children, and 2 out of the 3 children actually have sickle cell disease. So 2 of them have SSSS. I recall another family as well, same scenario. 2 out of the 3 are sicklers. Unfortunately for that one, management was an issue, and both were lost. So there's that. Then beyond that, you also have other couples. Well, it's a prevalent story. It's not something that is hidden. Just check sickle cell disease warriors. You find out the number of warriors that are there. They are doing very strongly. They are very brave. They are very strong. They are very resilient. However, it can also be a very painful thing to go through, and it can lead to questions as to why the parents would not really bring them into that kind of pain. But sometimes it's lack of information, sometimes it's knowing and still going ahead. However, for those now in a modern time, going ahead now has options. So option A is usually where it begins, and it's not as readily available in Nigeria, reason because of legality laws and all that. So sometimes the couple says, okay, we're going to get pregnant, and within every pregnancy we're going to do prenatal testing, test and see the genotype of the baby. If it happens to be an AA baby, we keep it. If it's an SS baby, we do terminations. We don't offer that service. We don't offer that. So there's that. But it can be gotten. Then beyond that, we say, okay, want to do it in a way that we want to be sure that it's an AA baby. So we're going to start in order of cost. So one option is that, okay, one of the couple sacrifices using their own genotype. So let's say they use a donor egg that is AA for the AS of the male, and they get a baby that is either AA or AS, and that is it. So randomly, that is, if you don't want to go through pregnancy screening because of the cost, pregnancy screening now, depending on where you're looking at it, where you're evaluating, can cost 8, 10, 20 million naira. It all depends on where you go to, a lot of other factors that may come into it, what you really need to, but I do like the range. On average, in our facilities now, the cross Warri, Port Harcourt, and Abuja is about 10 million naira on average. It's 7.5, 8, 10, depending on where, and that kind of thing. That is something that, so because of the cost, that they may not want to gravitate towards that. So with comparison, when you look at IVF, okay, let's use IUI first. The male semen gets a donor, you get a donor AA sperm, and we'll do an IUI, a donor IUI. Usually that will cost about 400, 500,000 naira. If all things being equal, maybe 600,000 naira if you add other machinations to it. And that is an affordable option. You know that the baby is likely going to be AA or AS because it's an AA semen that is going into mix with an AS oocyte, AS egg. That's what it is. Let's say that, okay, they are not comfortable with that. So, okay, we don't want to be the man's sperm. Let's use a donor embryo, a donor egg rather. So they can now go for that. The donor egg is now an AA egg, and they can just be randomly selected, knowing that it's either A or AS that's going to come out anyway. So whichever one is developing the fastest is what is now used. When you take that out of the equation, now okay, let's bring that back into the equation and look at the cost. So depending on where it is, right, the cost of a donor egg IVF usually would be 2 million, 2.5 million, 2.2, 2.5, depending on where it is. At the time of this video, Abuja has a promo that is going on that allows it to go for about 1.8 million naira. But I don't know where you're going to be getting this, where you're going to be seeing this, and the prices could vary, right? And by that time, it might possibly be over. But That's what it is. So you now look at those options. So I see that okay, that's the next step. But if you want to definitely use your own semen and your own egg, then you go for pre-genetic screening. The IVF procedure is done from beginning to the point of egg collection. It's collected and merged with the male semen. After it has been merged, the next thing, the fertilization has occurred. And the next thing to do is to test and see which ones are AA, which ones are SF, which ones are, so that's the pre-genetic screen. And only the ones that are AA are transferred back into the lady, and with that way she can get pregnant as an AS couple, and they can have a very healthy baby. Okay, how long will IVF take? IVF procedure take? That's a common question because maybe you're trying to plan how you're going to go about the procedure, the timing that you actually need. For most people, based on the protocols that we currently mostly follow, this is how it falls. So coming for your first test, your consultation, let's say you're coming in on the first day of January. Depending on your preparedness, usually consultation time is where most people are getting information. So they have to still go back, ruminate, decide on what they want to do. Some persons, however, like you that is watching this video, probably has gotten a lot of information. By the time they are coming in, they know that they want to start the procedure and they come in for consultation, get their initial preliminary examinations, and then move on to the next point where is testing. Testing has a duration that can vary. For testing, most times we want to test at the peak of certain hormones if the woman is on the younger side and we're considering using her eggs and she's in her periods. So that can take about 2 weeks apart, can take up to 4 weeks. Maybe we're doing a day, the initial testing on that day. We'll do some tests on day 2, we'll do some tests on day 10, we'll do some tests on day 21, whatever the machinations are, right? Using all of those ones, depending, maybe dependent on your where you're going to. But all things being equal, within one cycle, so within one circle for the lady, we're able to actually go through the procedure. So we do, let's say, a month of testing for both the female and the male. The male usually just needs about 3 to 5 days, mostly for the semen analysis to ascertain the seminal health of the man. Then after that has been done, we move on to the next point, which is result review. That one, just one visit, that's usually enough. Then the next step now depends on what we find. For some couples, we may need to place them on medications or some other procedure. Maybe that takes a couple of weeks, that takes a couple of months before we know whether we are going to an IVF. But let's presume that we're going straight to an IVF. So after the first testing has been done, the next thing that happens is going in for the IVF procedure, and the woman gets placed on some medications usually before a couple of weeks, can be 3 weeks, there about, let's say, on average about 2 to 3 weeks. Let's just say, presume maybe about a month. Usually it does not take that long. Then after that, you move into the next 3 weeks of the procedure where she's placed on some medications, usually an injection, some other injection to help with the stimulation of egg production, to help with the preparation of the the womb, of the uterus, the womb for the babies that are coming in. So that can take another like 3 weeks. So all things equal, being equal, that can take the IVF process can take about 6 to 8 weeks. We're presuming that everything goes as planned. So testing 4 weeks, 6 to 8 weeks for the other one. So it takes about a total of 2 to 3 months to complete the procedure from beginning to end if you are putting everything together. However, when couples are distant, sometimes maybe they are outside the country and we're trying to work with them, we may hope that they do their test where they are and send the results to us. And that means when they are coming in, they will come in for just that 6 to 8 weeks. There are times, however, when we are even up for them commencing the oral medications where they are, so for about 3 weeks before they come in and come in for the last 3 weeks. In the event of using a donor, what may happen is that because it's a donor egg, we don't even need the lady around till about the last week. So be on medications, who can guide on how to take some of the other drugs, the injections that we need her to take, and all those things. And we can definitely now fully on ground for only about a week. But it all depends on what we are looking at and what we're navigating. For example, in the timeline that I gave you, there are people that may have uterine fibroids that are too large to be, or the positions are not okay, or the effects are too unpalatable for us to continue. And in that kind of situation, they would have to remove the fibroids first. And after removing the fibroids, they have to wait for a period of healing before they can come back for the procedure and all of those things and all of those things. Okay. So IVF with fibroid, let's just dive into that as the next point. When it comes to doing IVF with uterine fibroids, there are a lot of factors to look at in that situation. The first thing to actually acknowledge is that fibroids are common, very common. Some studies argue that about 50% of women actually have uterine fibroids. Some may say 40, some may say 60, whatever within that range. But the point is simple and clear. Fibroids exist and they are common in women and they happen and may not necessarily be an issue. In fact, the most common symptom of uterine fibroids is no symptom at all, asymptomatic. That's what we doctors know. Most of the time, the fibroids that are found can be coincidental. She's been evaluated for something else, it's just routine evaluation, and then it is found that she has fibroids and those things that may be. However, there are a group of persons that already have symptomatic fibroids. And usually once fibroids are symptomatic, it's often an indication for the fact that something needs to be done. So by symptomatic, I mean they're bleeding excessively, menorrhagia, their periods are having issues, they're having intense pain from the fibroid, they may be having abdomen swelling up. The size of the womb is also meant to be about the size of your fist. So we call this about a 12, less than 12-week size, definitely the size of your fist. Then you start seeing anything above the pelvic region. You start understanding that what is happening there is that the womb has grown to about 12 weeks. Above that, when you start seeing that your navel level, you're looking about 22 weeks in size. By the time you start feeling that hard consistency, that hard thing beneath there, and you know that there's something growing there, then it's a problem. It needs to be removed. Not to even talk of women that now have situations whereby they are being told that, oh, they think they are pregnant, but they are not. It's just the fibroid growing. It needs to be removed before the procedure can be done. For some persons, maybe location. Maybe it's a small fibroid, but it's located at the point that obstructs the entry of semen, sperm, or it's located at the point that affects the tubes, those tubes that we were talking about before, from actually taking in or letting them to go out. Even if they are small, they need to be removed. Some of them, they are there, they are causing fluid to be in the womb, they need to be removed. So it all depends on what they are doing and not just if they are fibroids or not. Size, what they are doing, and their location, like their effects and their location are some factors that we'll look at to determine if a woman can do IVF with fibroids. So when that question is asked, the answer is not a generic question. On its own, yes, IVF can be done with fibroid, but it depends on the size, depends on the location, depends on the number of factors that now need to be ascertained before you can decide to go in and deal with that. Okay. The next common question that comes in is, doctor, I've done my IVF or I want to do my IVF and they're telling me that after doing IVF, I cannot go out, I cannot do this, I have to be admitted for 3 months, I have to stay indoors, I cannot do anything. And the answer is no. Do not be deceived. An IVF pregnancy is like every other pregnancy. Precious, we agree. Delicate and to be cared for, we agree. But it's because of the fact that we have ascribed that importance to it. Once a woman is pregnant, she can navigate everything just the same way a woman that got pregnant without assisted reproduction can. So of course we're not asking her to do the most strenuous of things or to swim oceans and jump mountains, but we are saying that she's not an egg. She can go about her daily activity just the same way a pregnant woman can work till a couple of months. She can work till a couple of months to her delivery or over to the last month of her delivery and all those things. Just rather that you don't do things that are rather too strenuous. Even after embryo transfer, once the embryo transfers occur within that 2 weeks, you don't necessarily need to take time off work. We recommend it. It's better for you to be in a rested state. However, it's not compulsory that you must take out that time from work before the procedure actually works for you. So those are things to look at in the whole machinations of everything and in navigating. So you don't need to be carried like an egg. Your regular stuff, if I don't want to be admitted, you also try the IVF procedure. it's a work. Most of the procedures that are doing are working. So you come in, you go out, you come in, you go out. Maybe depending on when you will now have to do your transfer of the embryo, will now want you to come to the hospital. Maybe if it's transferred at night, you stay, we'll monitor you, stay for maybe 24 hours, and that's just it. That's all that it takes. So, not ask the question of IVF is expensive, IVF is expensive. The thing I usually say about that is that you weigh the cost. What is more expensive? The money that is being spent, or not having the baby that you want, not having the family that you want. And the thing about it is that sometimes when people hear that IVF is expensive or it can be costly or things like that, what they do is that they just give up entirely. So if they were to break it down into a 1 year plan or something like that, you find out that you can actually raise up the money, or maybe it takes more than that, because of course realities are different. I'm just saying it depends on where your priorities are. You can decide to either accept the fact that IVF is expensive and then not do it at all and then just live life without your child, or you can brave the odds, get your thing done and move on. Okay, so we're going to be just looking at briefly at the causes of infertility. So when we're looking at the causes of infertility, what we are essentially saying is that what are the reasons why pregnancy can be delayed in couples? What are some of the reasons that we see and acknowledge as causes of delay in couples that are actually trying to get pregnant? And what we see there is this. What we see there is this. There are male and female factors, like we said before, and beyond that one, there are also unexplained infertility that into play. Actually comes into play. So for some of the main factors, what we're looking at is, let's say, I'm looking at issues with sperm production, while still looking at issues, anatomical issues with the passageway. I'm talking about hormonal problems that can actually be going on. Especially with sperm production, like oligospermia, there's reduced sperm. Azoospermia, there's no sperm in the semen at all. This can also come in from maybe drug abuse, alcohol use, excessive alcohol use, or it could even be mechanical. Let's say surgery was done around the area before, and because of that now, the man has some scarring that has prevented him from being able to give birth, being able to produce sperm. Sometimes we can go in and of course extract the sperm from there. But those are some of the causes that can actually come into play as to the cause of infertility. Cause of infertility. You can see maybe someone that had cancer before had to do some form of surgery. You now find out that okay, after the form of surgery has been done, it now has issues and all those things and all those things and all those things. Sometimes the sperm can even be produced, but they are abnormal. They may be having defective issues, shape, size, tail, head, whatever. And we know that that is where the problem is actually coming from. So a man that has had his testicles damaged will also have issues. So that is testicular surgery, testicular cancer comes into play. Then you also look at maybe sterilization, or even for some men, it's not that even there's even no semen. They are just having issues ejaculating or meeting with their wife. So you have to now extract for them and use IUI, whatever procedure, to get the woman pregnant. So there are cases like that, can be things like that. There are hypogonadism, where the gonads that has also produced a lot of hormones end up not producing those kind of hormones. Like case in point is testosterone, not producing enough of it, and that affects things. And mention the number of factors that can come in under male factor. It can even be health induced though. Medications, drugs can actually come into play and be the cause of the issues that we're actually facing. Then beyond that one, we are looking at things like okay, beyond that one, we'll now go down to the female causes. So I'm going to quickly run through this because I want this to be as easy as possible for everyone. Not something that is going to now be protracted in a way as if we're doing a medical lecture. That's why things are simple, things are fast. Okay. So in the female one, we can also look at it from multiple angles. You can see when anatomical, physiological issues that are actually going on. You can want to look at it like that. You can look at it from specific areas, because when it comes to the issue of reproduction, there are a lot of things that are actually working together. The brain is coming into it, so hormonal system is coming into it, the ovaries are playing their role, the fallopian tubes are doing what they know how to do, the uterus is doing what it knows how to do, the vagina has to have done its part and all those things. All of these things come together to allow fertility to occur. So let's start from the bottom. If a man is sleeping with a woman and yet she has an obstruction in the vagina and is able, anytime he releases, does not get into the cervix, to the mouth of the womb, the woman cannot get pregnant. Maybe it's being blocked by maybe scarring, or it's being blocked by fibroids, or whatever the reason may be. There's no way for her to get pregnant. In the same light, if she has her tubes, both of them blocked, there's no way for her to get pregnant as well. So you see, these are some of the things. But beyond that one, you can also look at the womb itself. If you have things like fibroids or that are in the womb that are obstructing the endometrial lining, which is usually where the baby will stay. So think of it like this. This is the womb. There's a middle line here, a middle area here that the baby is meant to implant in and then start growing on to expand the the womb. So if there are problems in that area, the person cannot get pregnant. If there are issues that are coming in from, excuse me, sorry, if there are issues that are coming in from, let's say, hormonal hormonal problems, the person will not get pregnant as well. These are some female factors that we're looking at now. If the ovaries are having problems carrying or they're having functional cysts that are disturbing them, the person can also not get pregnant. So they are, or will likely not, let me not say cannot, even within the ovaries, you can look at it like polycystic ovarian syndrome, which some persons have, where the development of follicles is, what would I what's the word, is impaired, so to say. So they develop, but develop in a periphery around the ovary. Beyond that one, they are not really maturing the way they should. This now comes on with problems with period regulation, longer periods, shorter periods, or things like that. These are all of the things that now come into play together that can now affect. These are some of the things, right? I'm not say all of the things, some of the things that can actually come into play that can affect pregnancy. Even premature ovarian failure, that is menopause that occurs before the age of 40, and it happens. One patient that got into menopause at the age of 35, at the age of 25, at the age of 30, premature ovarian failure. People that have issues with their thyroid glands and they are having hormonal production problems, they are not able to get pregnant as well. All of this interplay is coming on. Some people do some kind of surgeries and they're not going to able to get pregnant. We have things like even PID, just banana infections, can actually travel up and cause blockage to the tubes, can cause a lot of infection, a lot of things that can be affected that prevent them from getting pregnant as well. So sterilization is a medical one that we use where maybe with I have a couple like that. I've had, when I say I have a couple, think of many couples. Just a singular phase that we're using for that. Where the woman had had previous surgery, I thought she had completed her family size, and as such did bilateral tubal ligation, which refers to the cutting of the tubes, and it is hot, it is tight, it is ligated. Let me use the word tight. It is tight, and then depending on the method the person is using, buried or reflected or whatever. And after that is done, the woman now had failure in that marriage, got married to someone else, not inform him of this, and they're trying to get pregnant, but that's the cause of the issue. So there are things like that. Even drugs and medications can come into play and actually may affect things. Maybe the woman is on certain medications and all those things. Even things like spinal accounts are used for food reception when there's a lot of food in the person's body, they have to be stopped. Even of course, quite obviously, contraceptives are going to affect the ability to get pregnant. So those are some of the things that you can look at. And male factor infertility, we see about 30% of fertility issues come from that. Female, another 30% come from that. But we say about 10, to some places even 10. If the national health scheme for the United Kingdom will tell you that they have 1 in 4 patients that have unexplained fertility. 1 in 4, that's 25%. There is no explanation, there's no cause that can be having that is seen. So usually we say when a woman has been undergoing that for about 2 years, maybe you try some other basal methods or not. But been undergoing that for 2 years, we're looking at IVF. But if not for about a year, she comes to assisted reproduction technology and we'll see what can be done to help her to get pregnant. Some people get it with just medications or some other lifestyle medications, usually not that. Others get it from IUI, IVF, or surrogacy, or whatever other procedure that they embark on and that go to get pregnant. Mm. Okay. All right, enough here. Thank you.
If you like this video and you want more information about fertility, IVF, babies, surrogacy, IUI, and many other fertility procedures as well as medical issues, kindly subscribe, share, and like this video for more.